ऑडियो वीडियो नीचे से म्यूट कर देना।
अनम्यूट। ठीक है, ठीक है, चल रहा है भाई।
यस यस।
अभी रुको, वीडियो एक चलाना है, सबसे हैवी वाली वीडियो मैंने इसमें डाल दी है, आएगी कि नहीं मुझे पता नहीं। ये देखो अब चल रही है। हाँ, वॉइस भी देखना। Call it meningoencephalocele.
ओके मैं बोल।
This brain tissue may be functional or non-functional part of the brain.
वीडियो की आवाज।
So, meningoencephaloceles are broadly divided into congenital, acquired, and spontaneous
इतनी
varieties.
है, ये मैक्सिमम है।
Congenital meningoencephalocele is seen in early
मतलब
childhood.
अटक के तो नहीं चल रही, अब देखो। नहीं नहीं, परफेक्ट है। लिंक अपने पास ये आ रही है ना, स्पीड बराबर है। ठीक है, डन है। आवाज ठीक है ना? ठीक है, चलो अब मैं इसको सिर्फ म्यूट और
Respected delegates, we are about to start in next 2 minutes. I request you all to please join us in the hall. एक मिनट देते हैं. Good morning, respected doctors. My name is Nishant. I'm based at Mumbai head office, taking care of strategy and business for Clavam. It's my great pleasure to welcome you all to this 13th ENT Conclave, designed and developed by Team Clavam, ALKEM, under the guidance and the mentorship of Professor Dr. Milind Kirtane sir. Again, also I would like to extend my warm welcome to who, all the delegates who have gathered to the different centers of the city. Basically, this CME model is going to be a hybrid model. We have another 10 centers who are going to join us. So I would like to extend my warm welcome to the Patna, Ranchi, Guwahati, Bhubaneswar, Delhi, Chennai, Hyderabad, Indore, Lucknow and Varanasi center as well. Also, I would like to extend my warm welcome to the distinguished speaker who would travel across and to be with us today, Dr. Dwaipayan Mukherjee, who is traveling for us from Kolkata, Dr. Mubarak Khan, who is going to join us virtually, Dr. Kaushal Seth, he is also with us, Dr. Madhuri Mehta ma'am, she is going to join us virtually from Hisar, Dr. Gaurav Medikari, he is joined to join us virtually from Bangalore, Dr. Satish Jain sir, right now he is in Dubai. He is also going to join us to have a discussion on a very interesting topic. Dr. Sunita Shukla, Dr. Bachchi Hathiram ma'am, Dr. Subir Jain sir and Dr. Nitika Gupta, she is traveling from Jammu for us to be with us. So doctors, ALKEM Magna always supported the cause of otolaryngology in India across city, and to conducting this ENT conclave every year is one such endeavor in the same direction. So without any further delay, before proceeding for a formal inauguration, it's time to honor our mentor. It's time to honor our guide who is actually guide us from last so many years, last 13 years to conducting this ENT conclave. So may I please request Dr. Milind Kirtane sir to please come. And I also would like to call our associated Vice President, Mr. Prince Uppal, to please come and felicitate Dr. Milind Kirtane sir. I request Kirtane sir to please guide us.
Yeah, very good morning to all of you. Thank you, Team ALKEM, who've been supporting us through their unrestricted, unconditional grant for conducting educational programs for the last 13 years. Not only that, but to their credit, I would also say that they give us a completely free hand in organizing the program, choosing the speakers, topics, etc. They've never been product oriented, which is a great thing. Not only that, but they've helped us launch many of our younger colleagues with their books, which were launched at the ALKEM program, and then they have taken copies and distributed them. So they really have been working in the cause of continuing medical education selflessly. So thank you very much. Thank you to all of you, to all the speakers and the participants in the panel discussion. We'll introduce you as the program proceeds. Just one thing, that when we started this program, we used to get a lot of people from abroad traveling here. Today, I think we stand at a level where our own people are at the par with any international speaker. We've got people who work in the field with far more experience, and that's why we now have mainly gravitated down to having our own people who give us the benefit of their experience. But the pattern keeps on changing. Last year, we had live surgery. This year, we've got recorded videos because I felt that you have time for question answers. So this time we said each speaker will have half an hour. He'll present within that time, and whatever time remains after the presentation will be used for question answers. We get different requests. Some people say live surgery, some say cadaver dissection, some say panel discussions. So it would be helpful to us if by the end of the program today, I'm going to ask ALKEM to hand out a little feedback form where we want three things. One, what is the format of the program that you all prefer? What is the time duration of the program? Half a day, 1 day, 1.5 days, etc. that you prefer? And number three, if you have, for the next conclave, any topics you feel you would want covered, any speakers' names that you would like to suggest, because all of us may not know, in different pockets there are people doing fantastic work, and if you know of somebody who's doing that, please let us know. So these three things as a feedback will help us give you a much better program every subsequent year. So without further ado, once again, good morning to you, and thank you all of you for being present. I think we have to start the first session. We'll just start with the traditional lighting of the lamps. I would like to invite all the faculty, please.
Distinguished Dr. Dwaipan sir, Dr. Kaushal sir, Dr. Subir Jain, Dr. Nitika Gupta ma'am, Dr. Bachchi Hatira ma'am, Dr. Sunita Shukla.
You forgot to mention that Subir has come all the way from Indore, and he's here every year for the program. Sunita here?
I think she is not yet come. can you please see me and we'll begin the video. Dr. Mubarak Khan is joining.
Hello. Yeah, I think we go straight on to the program. The first session is by Dr. Mubarak Khan. He will be introduced, but I just want to say a real big thank you to him because he's in the middle of a conference that he's conducting, but in spite of that, he has made time for us. So Mubarak, thank you very much. Please.
So Dr. Mubarak, 67 publication in national and many prestigious international journal, 3 patent application for innovative endoscope holders in India and USA. One of the patent is granted. 18 IPRs from the designs and trademarks. Pioneer in the prominent and endoscopic two-handed ENT surgeries, constantly developing tools and techniques for it, training 120 plus surgeons across India and globally through the 13 master class till now in the Talegaon Dabade where he based. Author of 3 medical book and 1 philosophy. And Dr. Mubarak is also a good poem. He used to do a poetry as well. Author of many book chapters in the many blogs, including biochemistry. So I would like to welcome Dr. Mubarak Khan on the way from the Talegaon Dabade to please have your topic.
Good morning, all. First of all, thank you very much, Kirtane sir, for inviting me and team ALKEM for this opportunity. This is a video which has been already sent to the ALKEM team in an extensive cholesteatoma, which has been operated by two-handed technique using the endoscope holder. You can see that how it is managed with the endoscope holder and how beautifully you can use the endoscope as an exoscope and without microscope too, how you can manage the things. So can you play the video, Nishan? Hello? Good morning to all. Dr. Mubarak Khan from Talegaon Dabade, Pune. Today I will be demonstrating right ear extensive cholesteatoma surgery using endoscope and our patented endoscope holder called endo holder. Using 3 mm 0 degree endoscope, mini and oral incision is taken with 15 number blade and end oral speculum. Outer skin flap is created by third and fourth incision at 12 o'clock and 6 o'clock respectively. Flap is elevated with Plasters elevator. After applying 2x2 mastoid retractor, temporalis fascia is identified by simple dissection with curved artery forceps. Large temporalis fascia is harvested using the panoramic view of endoscope and angle is given by endoscope holder. One can use angled endoscope for the same purpose. You can see the panoramic view with the endoscope and harvesting of temporalis fascia through the mini and oral incision using endoscope as a exoscope. Tragal cartilage is harvested from same end oral incision. Whole harvestation of tragal cartilage is done by holding endoscope in endoscope holder and using intermittent digital zooming. 1.5 centimeter by 1.5 centimeter tragal cartilage can be harvested in adult. The same cartilage can be used for the different reconstructions in the middle ear and the soft wall reconstruction. Second 2x2 mastoid retractor is applied for better access and manipulation of two instruments along with 3 mm endoscope. Incision is taken at 6 o'clock to create tympanomeatal flap. Please note the working with two hands. Suction in left hand take care of heat generated by endoscope and avoids the fogging. It also helps in clearing the field during excessive bleeding. Elevation till 3 o'clock to create a 270-degree flap. Note the panoramic view with endoscope and flawless working while using it in endoscope holder. One need not to take endoscope in and out again and again for defogging. Simple aluminum foil piece obtained from catgut pack is used for protecting TM flap. Bone paste is collected from outer healthy mastoid cortex to be used later for the reconstruction of outer mastoid. During drilling, to avoid the damage to endoscope and canal skin, one can use auto shield, that is a drill bit protector with irrigation and suction channel, or careful drilling can be done by keeping endoscope bit away from drilling area and using digital zooming, that is using endoscope as an exoscope. We have designed a special set of angled instruments for elevating cholesteatoma sac all around. Note the benefits of two hands and panoramic view by endoscope during the dissecting the cholesteatoma sac. Panoramic view allows surgeon to keep watch on all areas of middle ear cleft to lessen the complications and create a very small cavity. The cholesteatoma sac is dissected from all sides so that it can be taken out in toto. Note the use of suction and angle instruments along with the panoramic view of endoscope held in endoscope holder while elevating the cholesteatoma sac and keeping the facial reach very high so that the cavity will be very small. It will be easy later on to reconstruct the cavity. Canalplasty and removal of posterior superior bony wall to access the facial races and sinus tympani using 2 millimeter coarse diamond burr. Whenever the lens gets spoiled with the bone dust, a simple irrigation can be used to clean the lens. Elevated cholesteatoma sac is excised in toto with the iris scissor. Note the working with 2 hands with the endoscope. Deep adhesive drum is dissected gently and carefully from high jugular bulb. Very carefully and gently tough adherent tympanic membrane and sac dissected from eroded facial nerve, stapes footplate, sinus tympani and posterior sinus. Note the use of the suction and the sickle and use of endoscope as an exoscope. Similarly, adhesive drum elevated from processus cochleariformis, stapes footplate, promontory, cog and anterior epitympanum and supratubal races. Note the use of suction and a sickle. The whole surgery is done under general anesthesia with hypotension. Instead of cotton plagiates, a nasal pack sponge soaked with the adrenaline is used to avoid leaving behind the lint in the middle ear. Adherent drum carefully elevated from antero-inferior area. High jugular bulb with bony wall erosion due to long-standing disease seen. The adherent drum is elevated from the promontory. While elevating the flap in antero-inferior area, it is noted that bony wall separating the carotid is eroded and pulsations are seen. Note the eroded bony plate separating the carotid, eroded stapes foot plate, jugular, and facial nerve. Note the pulsations of the internal carotid artery in the anterior surface of right middle ear cavity. The carotid is covered with the bone paste to protect and avoid the tinnitus. Stapes footplate mobility is checked. Mastoid is cleared of granulations and checked with the angled endoscope. (0.5% povidone iodine solution is used for the cartilage boomerang created with 12 mm length and 2 mm wide cartilage for type 3 ossiculoplasty. Irrigation. Strips of cartilage are prepared for creating a pseudomastoid. Pseudomastoid is created by soft wall reconstruction using tragal cartilage and platelet-rich fibrin sheets. All eroded areas in the middle ear cleft covered with platelet-rich fibrin sheets. These sheets are created by centrifuging the blood drawn from the patient and centrifuging it at 5,000 rotations for 15 minutes and then creating the sheets from this platelet-rich plasma. Temporalis fascia is used like a bed sheet for reconstruction of tympanic membrane and posterior canal wall. Tympanomeatal flap is reposed and it is covered with platelet-rich fibrin sheets. Again note, these platelet-rich fibrin sheets are created by centrifuging the patient's own blood with the 5,000 rotations for 15 minutes. Tympanomeatal flap along with temporalis fascia is elevated again for fitting the modified cartilage boomerang. The short arm of 4 mm is perfectly rested over the foot plate of the stapes, and the long arm rests in hypotympanum. This gives a very good stability and airborne gap closure up to 20 decibel postoperatively. Tympanomeatal flap is reposed back after addressing the small defects in the posterior canal wall. The bone paste is used to cover the cartilage soft wall only in peripheral parts. PRF sheets are used over bone paste and cartilage for providing the growth factors. Tympanomeatal flap is now reposed back over the soft wall reconstruction meticulously. Platelet-rich fibrin sheets also used over the reposed tympanomeatal flap. Platelet-rich fibrin has many growth factors, stem cells, and it helps in nourishing and potentiating the healing. Note the use of two hands, endoscope in endoholder, and the panoramic view achieved by the endoscope. External auditory canal is filled with antibiotic soaked abgel. End oral incision is sutured with absorbable 5O Vicryl. With mini end oral incision, there are only two small sutures. External auditory canal is packed with the antibiotic soaked gauze piece. Note the post-operative result after 3 months. Thank you very much for
Mubarak, can you hear me?
Yes, sir.
Fantastic demonstration. Congratulations and thank you for showing us this technique. What we would have liked to see is also how the endoscope holder from outside was looking. That we did not. You showed us the pure endoscopic picture, but people want to know what you have developed as an endoscopic holder and how it was held in position. Is there a possibility of showing us that?
We can show it because those videos are on the YouTube.
Okay. And secondly, a word about this fibrin film that you prepare from the patient's blood by centrifuging at 5,000 RPM. Can you tell us what the process exactly is? And
it's a simple process. The anesthetist draws a 20 ml of blood, and it centrifuge. The centrifuge costs you around only 11,000 to 12,000 rupees. So per month centrifuge is there in my OR, because we use a lot of platelet-rich plasma plus platelet-rich fibrin. So for the platelet-rich fibrin, without a coagulant, you immediately transfer this blood to the centrifuge and rotate it with a 5,000 RPM for 15 minutes and take out the test tubes out of the centrifuge, and whatever clot you get, that is nothing but a platelet-rich fibrin. With a simple IV on
so that will remain on top. The blood elements will, the cells will all go down.
Yes, sir.
So that you take out. How does it become a film?
Yes, sir. Just with a simple IV on pack, you press that clot, that's platelet clot, and you can create the sheets. Otherwise, in a graft press, you can put it and press it. That's all. It's very simple. Right?
Yeah.
And in a recent time, I have seen a beautiful result and fast healing with this platelet-rich fibrin. Even for the mastoid reconstruction, even for the middle ear, where the promoter
when you put your temporalis fascia graft, you place the fibrin film on that. Then you reposit the skin and put another film on that. Is it correct?
Yes, sir. Yeah. So the idea is that because dermatologists and orthopedicians, they are using, because we don't have a literature for this, but the dermatologists use it quite. Okay, that is a platelet-rich plasma and the platelet-rich fibrin. So for the facial rejuvenation, the idea is this platelet-rich fibrin has got a lot of growth factors, stem cells. So this helps in nourishing the wherever it is kept. That's one thing. And another, the hypothesis is that if you keep it on a certain tissue, it starts functioning like that tissue. Okay, so if you keep it over the bone, so it will function as a bone like that.
So when you centrifuge it for 15 minutes, the RBCs and the WBCs all go to the bottom, but the platelets still remain in the plasma. Is that what you're saying?
Yes, and it forms a clot there.
Okay. Any other questions from any of the centers? Guwahati? Any questions from Guwahati?
Yes, sir. Good morning, sir. Can you hear me?
Yeah. Good morning, Gautam.
Sir, I'd like to know there's a query for Dr. Mubarak. What is your long-term hearing outcomes with the L strut that you use for only for stapes foot plate?
For the long term, we have followed our patient because we have started doing this technique for the last 10 years. And the longest follow-up period is about around more than 5 years. And long-term results are quite encouraging. The airborne gap is closed up to 20 decibel. So previously, I used to use a lot of prosthesis, TOR, POP, course prosthesis, but extrusion and those problems were very high. So again, when I started experimenting with the cartilage, first I started using it as an TOR. Means I used to create an umbrella and keep it. So many of the time it used to get a tilt, and the results were not that encouraging with the umbrella. So then later on, I have seen ABR Desai sir putting this as an boomerang. So, but the problem of that boomerang was that because it has got the elasticity, and again it is used to get a straight one. So we started taking a small incision, cutting the perichondrium on one side and the cartilage, and keeping the perichondrium intact on the other side. You just bend it. So it beautifully fits over the foot plate, and it rests on the hypotympanum. If it doesn't rest in a hypotympanum, I make a small notch there, and then I put that long.
So you take one cut or two cuts on the dorsum to make it bend? Only one cut?
Only one cut. So on one side, the perichondrium is cut and the cartilage is cut. Other side, the perichondrium is intact. Okay. So it's beautifully bent. And over that, you can put a temporalis fascia and You can see the results and quite good results with this.
Yeah, Gautam,
And
one
the
more
only
question.
important thing is you have to preserve the perichondrium on
Both
both the
sides,
sides
both
of this.
sides.
Yeah.
Okay.
Then only the cartilage survives. If the perichondrium is not on one side, the chondrocytes are lost over the period, and then your results typically goes down. Yeah.
Thank you. Thank you very much. There's one-
Hyderabad, any questions?
So can we have one more query, sir?
Yes, please go ahead, Gautam. Please go ahead.
You could see during this surgery, the L strut was actually pressing on the exposed horizontal facial nerve. Your strut was actually resting in the superior on the horizontal exposed facial nerve. Will it cause any issues in the long run again?
No, not at all. See, we create a vertical vertical strut on one side, and it rests on the foot plate. Although it will be touching to the facial, but it doesn't press because your other arm is on the hypotympanum. If you put in just a simple vertical strut with a cartilage over it, that usually gives you a trouble at pressing over the facial nerve. Means in umbrella, if you create a cartilage umbrella and you keep it, so that will cause you the pressure over the facial, but not this boomerang, because the pressure is transferred towards the hypotympanum, not
because
over
you
the
have cut through the cartilage, keeping only
Yes.
the perichondrium intact. Okay.
Yes.
Hyderabad, any questions?
Yeah. See, some more queries about the same fibrin film. So, do you dry it like temporalis fascia before you place it in the middle cavity? Do you dry it?
No. You should not dry it. See, these are the vital structures. Okay, these are the fresh plasma, fresh platelets. So you should not dry it. If you dry it, the whole function of this.
No, he's asking about the temporalis fascia. Temporalis fascia.
For temporalis fascia, temporalis fascia, it doesn't make a difference.
No, I'm asking about the fibrin sheet only.
Fibrin-
We don't dry it. Okay. You don't dry it.
No, absolutely not. And you should not dry it. Otherwise, the whole intention of using it is gone.
Yeah. See, one more query is there from one of the delegates. See, will there be any cosmetic deformity after removing tragal cartilage? I don't think there will be, because you will be leaving the top of it intact.
Yes.
Right?
Till now, I have not seen any cosmetic deformity. Last 2 decades, I am doing this cartilage tympanoplasty. Even with the microscope, I used to harvest the tragal cartilage and use it. Okay. Now with the endoscope, but there is hardly any cosmetic deformity if you preserve that 5 millimeter tragal cartilage.
Yes, got it. Thank you.
Any other question, doctor, from Hyderabad?
No, sir.
Hello, sir. Can we go to Lucknow now? Lucknow, any questions?
Yes, sir. Excellent demonstration, Mubarak, sir.
Hyderabad has one more question, I think. Just 1 minute, Lucknow, hold on.
The posterior part of the mastoid cavity, you just obliterated with bone dust, or did you use cartilage also to?
No. It is not obliteration. Have you seen that? I have kept 2 strips to create a mosaic downward. The idea is to create a new mastoid, and then I create a nice L-shaped cartilage strut which is kept over that. So underneath there is a air, and this is communicated to the epitympanum. The whatever bony paste we have used, it is over the cartilage, and that too in the peripheral part. Okay, so create that to give that support outside. So this doesn't blocking the whole of the mastoid, or it's not an obliteration. So it's a creation of the new mastoid.
You want to create a new mastoid which is slightly smaller in size.
Exactly.
What about the attic, sir? Do you reconstruct the outer attic wall, or you just drape
this same cartilage usually I modify. If it is a short one, I put another strut there and then create, because you need to have that solid support in the attic and in the soft wall reconstruction, so that the sagging of the posterior canal wall will not be there, and the post-operatively in the long run the retraction will not happen.
And you're keeping the adductus patent.
Yes, that is all important for the functional endoscopic middle ear surgery.
Thank you very much. Thank you. Lucknow, any questions?
Yes, sir. Excellent demonstration, Mubarak, sir.
Yes, thank you.
Your field was very clear. I mean, what was the infiltration you used? I mean, did you had some kind of changes in that?
Yeah, this The infiltration is a routine, that's a xylocaine with adrenaline, but the crux is the hypotensive anesthesia. I use all my cases under general anesthesia. The anesthesia is a fantastic nowadays, and my anesthetist gives me 90/60. And most important thing is a pulse rate should be less than 70, and then you get this crystal clear field. So it's even if you don't use the adrenaline, due to this hypotensive anesthesia, you will have this wonderful field, and that is what is needed for the endoscopic ear surgery.
Okay, thank you, sir. Another thing is like you made bone paste. We know what is bone dust. So anything you added to bone dust to make it bone paste?
Yes, that's a very good question. Here again, I add a PRP. Okay, whatever that platelet-rich plasma is there, and it's like a glue-like. So you put it inside and make it paste. Put some antibiotic drops, and the paste is ready.
Okay. Another thing is like you use, sir, bone paste in the mastoid obliteration kind of a small.
Don't call it obliteration. We are not obliterating. We are not touching the cells.
And then again, you have placed fibrin sheets over that.
Yes.
Just to bury it down.
Yes. This only idea is to give the growth factors for the nourishment of that whatever structure is there underneath. Let it be a bone, let it be a cartilage, and let it be a skin if you are using it over the skin. Okay, so the idea is to give an nourishment and faster healing.
Okay. Thank you, Mubarak. I think we have to now move on to the next speaker. Just before you close, there is one question here. Can platelet-rich plasma be used as an alternative to tissue glue?
Alternative?
To tissue glue in endoscopic sinus surgery. You know, fibrin glue that is used for
really a good question. Yes, sir. Yes, sir. That is what we are trying now. And if you'll create nice, and it's very in 15 minutes it's ready. So we have to try that, sir. Now we are trying. So wherever we are trying it in atrophic rhinitis at present, and then we are trying it in on different bare bones we create while doing the functional endoscopic sinus surgery, but not lot experience with nose. But that definitely we can try that, sir, like as a tissue glue.
Okay. Thank you very much, Mubarak. I think you deserve a big hand from everybody. And
thank you so much, sir.
Ranchi, we will ask the questions to the next speaker now because we have to go on. They've overshooting the time, so the other speakers are waiting. So Ranchi, excuse us. You'll get your chance with the next speaker to ask the questions. But I'm sure you can write to Mubarak on his email. Mubarak, what's your email?
Yes. Sir, ENT, that is our favorite subject, ENT.Khan, KHAN @gmail.
ENT.Khan@gmail.com. So if you have queries, you can write to him, and I'm sure he'll oblige us by giving you the answers. Thank you once again, and I think you can get back to your
videos are there.
Okay.
Yes.
Okay, you can get back to your conference. Thank you for sparing your time.
Thank you so much, sir, once again for the. Yes, sir. And thank you very much, sir, for giving this opportunity. Thank you, sir.
So now the next speaker is Dr. Kaushal Seth from Mumbai. He is a AOI National Honorable Secretary. He is an editorial board member for Otolaryngology and Head and Neck Surgery, an international online journal. He also has a gold medal in DORL examination in 2001. He has a Best Thesis Award in the MS examination in 2002, delivered Dr. Satyanarayan Roy Memorial Orientation in Annual AOI WB Conference in 2022. Mini fellowship he has done in OSA Singapore. Faculty and co-chairman first robotic live surgery course on OSA in Asian Heart Institute in 2013. Invited national speaker for obstructive sleep apnea at more than 35 conferences, seminar, workshop. Pioneer of coagulation and robotic OSA surgery. So I would like to request.
Mrs. Vanil, I welcome you all for the 13th ENT Conclave. Already it is 13 years we have completed in ENT Conclave, as you know. Is the 13th.
Request to please play Dr. Kaushal Seth presentation on the main screen.
Good morning, everybody. At the outset, I would like to express my sincere gratitude to Kirtane sir for giving me this opportunity
And I request all the
providing us this wonderful platform. So today I will be talking about coblation adenotonsillectomy. We've all learned tonsillectomy in the conventional dissection way during our residency and training days. As technology has progressed, we have also started using newer equipments like electrocautery, laser, and finally coblation for our patients. Most of the patients with conventional adenotonsillectomy do well. However, few of them do present with primary or secondary or reactionary hemorrhage, damage to surrounding structures, damage to eustachian tube, which ultimately leads to stenosis and secretory otitis media, and in some cases, velopharyngeal insufficiency, which is a little difficult to deal with. Nowadays, with the advent of good antibiotics, the incidence of tonsillitis has reduced. We see fewer patients of tonsillitis. However, with the increase in cases of allergic rhinitis, pollution, smoking in adults, and of course, patients who have these remnants of choanal adenoids present in our OPD with different symptoms of nasal blockage, mouth breathing, symptoms of pediatric OSA, and so many other things. So what do we offer these patients as a remedy? That's where coblation does come in. Coblation uses electrical energy to excite the ions in a conductive medium like saline, thus creating a precisely focused plasma field. These energized particles, which have sufficient energy to break and dissociate the molecular bonds, they do this at a very low temperature of 40 to 70 degrees centigrade only. Thus, coblation excises and dissolves the tissue while preserving the integrity of the surrounding healthy tissue. In this comparison table between coblation and the conventional electrosurgical devices, we see that the temperatures attained are about 400 to 600 degrees centigrade when you use an electrocautery. This leads to deep, rapid heating, charring, whereas with coblation, a temperature of only 40 to 70 degrees centigrade is achieved. This leads to a gentle removal and dissolution of the tissues with minimal charring, minimal burning, and minimal collateral damage to the surrounding structures and tissues. Let us discuss a case of adult tonsillectomy. So this is a 20-year-old boy in which the patient has been given nasal intubation and put in the tonsil position by applying a Boyle-Davis gag. The basic requirement for a coblation tonsillectomy is a good microscope, because this microscope helps you not only in doing fine dissection but also to prevent complications. It's always a good and a definite handy thing to keep the conventional instruments in your tray. Let us discuss coblation of the right tonsillectomy. This was done in the same patient. The right tonsil is held by the Boyle-Davis tonsil holding forceps, pulled medially to see the elasticity. Here you can see that I am doing marking of the field. This I call as tattoo marking, so that this actually delineates and in fact shows you the boundaries of your dissection. You can start the dissection either from the inferior pole or from the superior pole. Either ways, whatever you are comfortable with. The idea is to go into a proper plane of dissection. When you pull the tonsil medially and you start dissecting, gradually you will start seeing the muscle fibers. Now, between the muscle fibers and the tonsillar capsule, you will see a loose areolar connective tissue. That is your plane of cleavage, and that's exactly the plane where you should continue with your dissection. If you stray away from this field, if you dig into the tonsillar bed, which has the muscular component, you land up with a lot of bleeding to control. At all points of time, your wand should face medially, as you can see in this video. Your dissection should be slow and targeted towards the plane of cleavage. Gradually, as you dissect the tonsil away from the base, you may encounter small bleeders which can be taken care of by the same wand. Now the wand that we use here is the EVAC 70 wand with 7 and 3 settings, which are the standard settings. Here you will see that as you pull the tonsil medially, you should also try and avert it. Towards the superior pole, you will come across small multiple vessels. Go on coagulating them, achieving hemostasis. At the same time, continue with your dissection with your wand facing medially. As you approach the superior pole, you may encounter a small twig of the uvular artery or the uvular artery itself, which will cause a lot of bleeding and it will make your field worse. Any bleeder which has a diameter of about 3 millimeters can be easily coagulated with this wand. The tonsillar artery also falls in this range, and if by chance you do injure the tonsillar artery, you can always coagulate it with this EVAC 70 wand. Use copious amounts of saline. Saline is the key to your dissection. If you do not use adequate saline, the suction tip of the wand will get blocked, and repeated blocking of the wand will lead to inefficient dissection, and it may even cause charring and bleeding. When you pull the tonsil medially, you apply traction, you can see a lot of these blood vessels arising from the bed and going into the, you can see here, this was a vessel of about 2 millimeter or maybe 1.5 millimeter diameter, which was easily taken care of. And in cases where there is a lot of tonsillitis, you will see a lot of adhesion, and because of adhesion there's a lot of neovascular genesis. You will see a lot of blood vessels which may irritate the field and cause a lot of bleeding. Gradually, slowly, as you progress, you can give a very clear field. This is a very simple bloodless procedure actually, if you go to see, provided you follow the principles of the surgery, you be in the plane of dissection and you go on cauterizing all the small vessels that come your way. Now we are reaching towards the end of this surgery where you can see the tonsillar fossa. This is completely clear. Under the microscope, you can remove each and every small bit of tonsillar tissue if you've left behind. It is a tip here is that you could leave a sliver of small tissue near the superior pole or at the inferior pole where the tonsillar artery is there. That will help you a lot in cases where there is post-operative inflammation and edema, so that hemorrhage and secondary infection doesn't set in. Slowly, we are now dissecting the tonsil away along with its capsule. So this is an extracapsular tonsillectomy that we have just performed. We will see a left tonsillectomy being performed. A left tonsillectomy being performed in a small child of about 7-year-old. The point to understand here is that in a child, your area of your operative field, your area of play is very small, very minimal as compared to an adult. Plus you have the endotracheal tube coming in the picture. So your maneuverability is a challenge, but with a good learning curve, you should be able to overcome this. You can see here in this particular video that I'm showing, I'm gradually dissecting the tonsil away in that same plane, I'm being very careful not to injure the muscular bed, which would lead to bleeding and post-operative inflammation and pain. If you stay away from the muscular bed, you can actually give the patient a good post-operative experience. Do not, the wand should always face medially. If the wand faces laterally, that's where the complications can happen. Here you can see I'm dissecting in the plane between the muscle and the capsule, this loose areolar tissue, all small vessels which come in the way can be easily cauterized. Use a good copious amount of saline. The settings of the saline should be on auto mode, so that the moment you press the pedal of the wand, you have a copious irrigation coming in. We always use normal saline, and if you refrigerate it overnight, it gives a better field. Here you can see that the muscular layer has not been touched upon. Near the superior pole, be careful of the uvula, because the suction which is attached to your wand is very powerful, and at times it can just suck the uvula into the face of the wand, leading to a lot of mucosal injury and bleeding. It leads to post-operative uvular edema and a lot of pain. So be a little careful and gentle in a pediatric age group, because your working space is very minimal. So your movements should be optimum. Maneuverability is a challenge, but if you keep the wand facing medially at all possible times, you should be able to do a good job. Now this is the end of the procedure of left tonsillectomy done in a 7-year-old child, and there was hardly a speck of blood. You can see this in this post-op. So this is a healthy. Now, coblation adenoidectomy does come with its set of advantages, in that it facilitates a complete removal of adenoid tissue under a direct vision. The bleeding is very minimal and the removal is precise. The choanal adenoids can be easily accessed, and under vision, under endoscopic vision, you can do a complete clearance without damage to the eustachian tube or the surrounding structures. Now, in a pediatric age group patient, when you're doing tonsillectomy, adenotonsillectomy, before doing the tonsillectomy, it's a good idea to pack the nose with pledgets and cotton patties. This would decongest the entire area by the time you finish your tonsillectomy. And once you finish your tonsillectomy, you have this wide nasal cavity open for your access. And you pass in your sinuscope. I usually use a 2.7 millimeter rigid sinuscope in pediatric age group. Pass it through the nasal cavity, and through the other side you pass in a small suction catheter which is used to pull and retract the palate, thus giving adequate space for your wand to enter. Now this, we use the same EVAC 70 wand which we have used for tonsillectomy. However, this wand being straight, there is no way that if it's introduced inside without it being bent, would it be able to reach the roof of the nasopharynx. So you do bend this wand to about 25 degrees angulation, because it's malleable, and at that angulation, even the suction the boundaries of adenoidectomy. Now this is the adenoid tissue. Posteriorly is the pharyngobasilar fascia. Inferiorly is the passavans ridge. On either sides, laterally is the torus tubaris. Above that is the fossa of Rosenmuller, and in between two are the eustachian tube openings. The roof of the nasopharynx is bound by the periosteum of the basisphenoid. So these are the boundaries, and we need to be right in the center and not breach any of them. Let's see a case of coblation adenoidectomy being done in a 7-year-old child. The 2.7 degree rigid telescope has been introduced through the left nostril. The EVAC 70 wand, which has been bent at 25-degree angle, has been inserted from the oral cavity. And once you introduce it, you first have a tactile feel of the tissue. You start coblation then from the inferior end, and then gradually move towards the roof. As you reach the roof, you can easily ablate all this adenoid tissue. You should never dig in your EVAC 70 wand into the adenoid tissue, because that will lead to a blockage and it can lead to a lot of complications. So throughout the surgery, your wand should be under vision. You should be able to see all the 3 electrodes. Here you see I am staying in the center. Whatever small blood vessels, bleeders that I encounter are easily taken care of. Hemostasis is achieved because coblation adenoidectomy is a very simple bloodless procedure if done properly. There is no other instrument which can reach the roof of the nasopharynx in this fashion. The coblation procedure does a good volumetric reduction of the adenoid in the center. You should leave the torus tuberous and the other important structures on the side. Do not touch them. Of course, you can remove a little bit of lymphoid hypertrophic tissue on the medial aspect of the torus, but do not do a volumetric reduction of the torus itself. See, you go layer by layer, don't dig in. Your posterior limit is the pharyngobasilar fascia, but it's in my experience, if you leave a sliver of tissue over the pharyngobasilar fascia and do not expose the fascia completely at all places, then you will probably avoid a lot of complications. So this is coblation adenoidectomy being done with the endoscope introduced through the right nostril and the wand through the oropharynx right up to the nasopharynx. All these small vessels are being cauterized. At the same time, a good volumetric reduction of the adenoid has been done. You can see the other side adenoid. Now you should not be removing your scope and reinserting the scope again and again, because that may lead to a lot of mucosal damage to the nasal mucosa, which will again result in bleeding and adhesions and whatnot. It will just increase your surgical time, and you'll repeatedly have a lot of bleeding to tackle with. So if your scope does get smudged or fogged, all you can do is, first thing, either you introduce your scope right into the nasopharynx and touch the adenoid tissue, because you've been using a lot of copious saline there. That itself will clean your scope. Or else you can ask your sister, your assistant, to flush the nasal cavity in which your scope is. That will clean up your scope, and you will not have to repeatedly remove your scope and reinsert it. So now we finished the adenoidectomy on this side almost. We will go to the other side and probably do remove the remaining tissue. Here I am just seeing whether there is any bleeder. I am just removing the tissue that is still left. The entire choanal area opens up once you do this sort of a tonsillectomy procedure, and the patient really benefits, gets a good nasal breathing, and most of his symptoms get alleviated. This is an unedited video that I'm showing. You go on removing and do a good reduction. See, I have never dug the wand into the adenoid tissue. Now I have removed the scope. I'm putting in the scope through the left nostril. You can see this is the remaining adenoid tissue. And in the similar fashion, starting from the base, without jutting the wand deep into the tonsillar tissue, I go on removing layer by layer, starting from the inferior edge, going right up till the roof of the nasopharynx and removing these choanal adenoids. You may encounter few blood vessels there, few small twigs, capillaries, and you can easily coagulate them using this wand. The settings for adenoids are 9 and 5. These are the standard settings, and usually your entire coblation adenoidectomy, if done in the right way, should get over within 10 to 15 minutes. So that's the torus on your right side. Be very careful not to injure those structures. Stay in the center. Go on doing a volumetric reduction of the adenoid tissue till you can see the pharyngobasilar fascia. Leave a little bit of sliver of tissue on that. You may encounter brisk bleeding on the lateral side, but these small vessels can easily be taken care of. And as we come to the end of the procedure, this is the final outcome, wherein I have removed the entire adenoid tissue, leaving the important structures on the lateral. Now, we have already mentioned the advantages, but there are lots of disadvantages also, in that it has a steep learning curve. Secondary bleeding in your early cases in post-operative period is a reality. It happens with everyone and happened with me also. Wands are very expensive, and the higher cost of the consumables itself is a deterrent. No procedure is bereft of complications, and coblation is no exception. I'll show you two complications that can happen. Now, this is bleeding. This happens if you go through the muscle into the tonsil, and then you'll end up having a lot of bleeding. And this has happened in the early post-op, when we had extubated the patient and we had to take the patient in again, simply because the muscle layer was breached and the bleeding had started again. Comparison between a dissection method and coblation method, and in this particular report, which was published in the International Journal of Otolaryngology and Head Neck Surgery in 2019, said that this new technique of coblation offered significant advantages in the post-operative period and was associated with less post-operative pain and early return to daily activities. There was also a study between coblation and cold dissection, which concluded saying that this coblation plasma tonsillectomy represented an innovation that provided benefit both to the surgeon and the patient, including the possibility to excise the tissue and coagulate the bleeding vessels with the same device at the same time, therefore improving the quality of post-operative recovery to that of cold steam. So, at the end, I would like to conclude saying that coblation adenoidectomy has indeed been a game changer in my practice, and I am sure most of the people will agree to that. Thank you very much for a patient listening.
Thank you very much, Kaushal. Fantastic demonstration. Points well covered, and I think your videos were very, very clear. Excellent. So, any questions now? Ranchi, you were wanting to ask questions, so have a go if you have any questions now. You have to unmute yourself, Ranchi. You're muted.
Hello.
Ranchi has to be unmuted. We cannot hear Ranchi. Vishant, who's going to unmute them?
Yeah.
Okay, Ranchi. Yeah, go ahead, Ranchi.
I'm Dr. Mulka from Bokaro. Excellent demonstration also. Just one point from my side about the movement of the arm in the adenoid should be like 10 plus. It should be very gentle. In the era of degraders that we used to use for adenoid before the coagulator.
We are not able to get you clearly, doctor. Can you hold the microphone close to you and talk a little slowly, because we are not understanding.
Can you hear me now, sir?
Yeah, go ahead.
Sir, yeah. Dr. Kaushal, excellent discussion. The movement of the coagulator. Are you getting me, sir?
No, sir, I'm not able to hear you clearly. It's kind of muffled.
Okay.
Hello.
Yeah, now you are getting that?
Yes, sir, go ahead, sir. We'll try.
Excellent demonstration, Paul. Only thing I wanted to make a comment that
I think, Ranchi, something wrong. We are not able to understand. The words are getting sort of.
Dr. Mukka, can you send me on WhatsApp?
Okay.
I'll probably read it out.
Yeah. Okay.
Or send me a voice message.
Yeah, I will.
Okay, can we have anybody from Chennai? Any questions from Chennai?
Regarding this coblation tonsillectomy, conventionally we see the tonsil being released from the superior pole, then we go to the inferior, reach the inferior pole. But here we see the tonsil being dissected from the inferior pole and laterally, and then last we approach the superior pole. Is there any advantage by this method? And another thing about the pain. First initial 3-4 days, the pain is very, very less. But from the 4th day, the patient complains of pain. So what is your experience on that?
Yeah, so as I said, you can start dissection right from superior pole or the inferior pole, whatever you're comfortable with. I am more comfortable with the inferior pole because I would actually like to trace the tonsillar artery and leave a sliver of tissue there and then go forward and remove the tonsil from its base. About the post-operative pain, yes, there is pain. I wouldn't say that it's a complete painless procedure. The pain is there, but the requirement for NSAIDs goes down drastically. That is if you stay clear of the tonsillar bed.
So
the moment you dig in, more tissue that you ablate, you're going to give more post-operative edema and post-operative pain.
Because the patient is now in the first 3 days, patient is very happy. When he experiences the pain suddenly on the 4th day, he becomes more agitated. Whereas in a traditional conventional tonsillectomy, the patient is prepared for the pain on the day 1 itself. So the tolerability to pain is also better, I feel, in conventional tonsillectomy.
No, see, first of all, don't promise the moon to your patients in the pre-op period that it's going to be a painless thing. The experience of pain would vary from a patient to patient. So be very, very clear that you are going to have pain. It may increase, it may decrease, and depending on your pain, you can take the NSAIDs accordingly. But in my experience, I have seen that the number of days that the patient has to take NSAIDs is far less than a conventional tonsillectomy.
Okay, thank you. Any questions from?
Excuse me, sir, one more question.
Yes, Chennai, go ahead.
If you breach the pharyngobasilar fascia during the adenectomy, what are the complications we encounter and how will you manage?
Sir, can you repeat, sir? We could not.
If you breach the pharyngobasilar fascia.
Yes.
Yes.
What are the complications you experience when you reach the pharynx?
So the most dreaded complication we all worried about is torticollis. I have seen that in one patient. And that's very, very difficult to treat. Takes a couple of weeks for it to settle down. And
it's called the Grisel syndrome.
Yes.
So due to what, sir? Due to what you get the torticollis?
Physiotherapy.
Yeah. If you breach that fascia, there'll be inflammation and bleeding there. And the only thing is rest, NSAIDs, physiotherapy, and it should go away on its own.
The torticollis is due to what?
The muscles going into spasm.
Okay.
Bhuvaneshwar, any questions? Bhuvaneshwar.
Sir, I have a question.
No questions? Patna, any questions?
Sir, I've got his voice message. Can I read it out from Patna?
1 minute. Patna, any questions? Patna? No questions from Patna. So one, Ranchi, there is a question which has come by WhatsApp. Go ahead. Just read it out.
Demonstration was crystal clear. Earlier in the era of the bride, for the adenoids, we used to operate from below, whereas with the gobletter, we go from side by side and the movement should be like brush and pen. Then there are some questions about the wand. There are different brands available. Which brand we should use? Another question is, if the adenoid is causing symptoms, should we remove only adenoid or tonsils as well? Third question is, what are the chances of hemorrhage and how to deal with it?
Okay, so from what I could gather in this, Dr. Moonka from Ranchi was asking whether with debrider they used to do adenoidectomy from below and coblation side to side. I mean, that's how the coblation wand functions. If you dig in, you're going to block the suction. So you have to be very superficial, maybe half a millimeter, 1 millimeter away from the tissue, and keep on moving the wand in a wavy fashion. That's how the tissue will get ablated. Regarding adenoidectomy hemorrhage post-operatively, I have come across one patient in my practice, and that was torrential bleed, probably because of an aberrant pharyngeal artery there, and I had to control it with finally packing with Surgicel.
What about the choice of the wand he wanted?
Yeah, so I would not like to name the company, any company. Earlier it used to be a patented product, now it's a wide open market. So there are wands available at probably all price points, whatever is your choice.
Okay. Guwahati has a question.
Sir, Kirtane sir, I have a couple of questions after you finish all the
Varanasi, anybody? Guwahati is trying to get the microphone on. Yes, go ahead.
I'm Dr. Anjali Barua from Guwahati.
Hello, madam.
I would like to know, in adenoidectomy, coblation adenoidectomy, 100% removal is necessary or not?
No, that's a good question. See, it's only the choanal adenoids which causes the problem, and that's where none of your conventional curettage or your debrider can reach. So if you remove that part completely, you're going to give a good post-operative result. You need not remove each and every follicle, lymphoid follicle out there. As I said, you can leave a sliver of tissue over the pharyngobasilar fascia. If you've removed 90% in the center, leaving a small sliver behind, I have not seen it actually hypertrophy and grow back again, provided you've taken care of the allergic rhinitis component and other factors which could have caused the hypertrophy.
Kaushal would like to disagree with you there that the debrider cannot reach there.
Sorry.
The 60 rad blade of the debrider can reach not up to the choana, but even inside the choana. And if you're not careful, you might even, debride the posterior end of the middle turbinate. So
Okay,
it can reach all the way there because it's a, you're bending your wand to 25 degrees. We use a 60 rad blade. It can go all the way up there. I think Guwahati has one more question.
Yeah, how to decide for intracapsular or extracapsular coblation tonsillectomy? For intracapsular or extracapsular?
Okay, so extracapsular we would do for recurrent cases of recurrent tonsillitis in age group of more than 6 years. But in a pediatric age group of 3, 4, 5 years, where the patient is presenting with symptoms of pediatric OSA and you need to give relief, that's where you do an intracapsular. You leave the capsule intact to preserve the immunity of the patient.
Okay, any questions from Varanasi?
Yes, sir. Good morning, sir. I would like to know the setting for adenoid for wand, sir. You have told for tonsil it is 7-3.
Yeah.
What is the setting? Is it same or different, sir?
I had mentioned, I'll repeat it again. You can make it 9 and 5.
Okay, sir. Then what is the minimum age for adenoid, sir, for coblation adenoidectomy?
So see, the minimum age would depend on whether the patient can be given anesthesia or no. The smallest child that I have done in adenoidectomy is 2 years. Beyond that, I may be a little conservative in my management. Wait for the child to grow up.
Thank you.
Hyderabad, any question?
Hello, sir.
Hyderabad, yes.
Sir, do you advise position, Rose position? I have seen so many patients having this Dressler syndrome. Since then, I have been doing tonsil in supine position. I have seen the pain is less, the spasm and this Dressler syndrome. What is your experience?
I agree with you on this.
The position, Rose position, the traditional
So don't have to
Rose
hyperextend.
Yes, I agree with you.
I'm doing in supine position.
Okay,
What is your...
See, only in cases where you have an endophytic tonsil. See, there are 2 types of tonsil hypertrophy, exophytic and endophytic. in an endophytic, if you really need to get the inferior pole exposed more, that's where you should be giving a extension.
So otherwise you prefer not to?
Yes, sir.
Okay, and one more question now from here, Mumbai. Vikram?
Yeah.
Go ahead.
So the question is to both you and Kaushal. Sir, you represent an era where, the gauze tonsillectomy was done. And now we have Kaushal's era of advanced technology where a microscope is used and a coblator is used. The end result is the same, although the finesse is much more. So, sir, what I want to know is that from you, sir, that you have done in your career as, incision with a 12-number blade and, gauze piece dissection. Sir, would you endorse today's method as being cost effective? We are keeping the safety factor aside because post-operative pain, delayed post-operative pain, secondary hemorrhage, we know is the incidences are more with the coblation technique.
I think, people are also talking about doing tonsillectomy with a laser.
Yes, sir.
Right? Or radio frequency.
Bipolar also.
Bipolar. So the point is none of these have shown a significant reduction in pain. There may be minor differences. Why you said first 3 days nothing and then the pain starts. Expenses is something which I think each individual patient has to decide. The patient has to pay a little more. If you use a wand, then he has to pay extra for the wand, yes. But I don't think that should be a consideration. Each surgeon chooses what he feels is best and can go ahead. And I'm sure all the patients are told in advance what is going to cost them. So, Vikram, I don't think cost should answer to this, provided you're giving the patient a good result.
So my second question is to Kaushal.
I'd like to add something. It's your technique and skill which will matter and not the technology. You can go a wonderful result even today with cold steel.
Correct. Kaushal, second question to you is how to increase wand life? Because the companies say use it once, it is a disposable, but we all, would want to use it 2 or 3 times, maybe up to 4 or 5 times if we are very careful with our wand settings and techniques. So can you highlight a bit on that? Because that's a recurring cost which every surgeon wants to save. Let us be very practical.
See, the maximum use of the wand happens during adenoidectomy. More the hypertrophy of the adenoid, more is the wand usage going to happen. According to me, on an average, not more than 2 times should you be using the wand, even though the wand is maybe usable for the 3rd time, because then you're increasing your chances of post-operative infection, inflammation, and hemorrhage.
Vikram's questions are also related and always related to the financial aspect.
Yes.
Anyway, I think we'll have to go ahead with the next speaker.
Yes,
Kaushal,
sir.
thank you very
Thank
much.
you, sir.
Deserve a very big hand. Yeah.
Thank you, sir, for giving me this opportunity.
Milind.
Yeah.
Milind, Dwarak here. So,
yeah, Dwarak. Go ahead, Dwarak.
Before I think Madhuri takes over, I thought I just want to congratulate the entire team of ALKEM and especially you and all. This time at least I can say hello to every one of you across the country. So thanks a lot and all the best to the entire team and all the speakers also. It's a wonderful.
Thank you, Dwarak. And I want to ask you a question. How do you manage to keep on looking the same year after year after year after year? What's the secret?
It's all, see, we are all, that's what, ultimately the things, let me follow Milind and other people follow me, something like that. Okay.
Okay. We're waiting for Madhuri now to come on.
Yeah. Thanks a lot. Right. It's go on to Madhuri. Right.
Good afternoon, dear friends. I'm Dr. Madhuri Mehta. My heartiest thanks to Team ENT Conclave and our teacher, mentor, and the scientific coordinator, Dr. Milind Kirtane sir, for giving me this opportunity to be part of this prestigious webinar. I hope I contribute well. It is almost 10 years that I, connected with the ENT Conclave team through sir only 10 years back in 2013, and the togetherness is great, and I want to keep associated with you all forever. So I will share my screen for the topic. It is not showing.
No, we are seeing your picture, but I think we need to share your screen. Yeah.
To share the screen.
Yeah, go down.
It is not. Okay.
Yeah, it's coming. It's coming. Just open your presentation.
I have opened it up. Okay. So
it's come. Yeah. Okay.
it's come?
Yeah.
Will I go to the this thing?
You can see a beautiful green garden over there. Yes.
That is our place where I work and live. And I'll be talking about nasal meningoencephalocele. It is different situations in management. As sir keep telling that if you want to train or teach people, then you must focus on single technique and tell it in details. I tried that, but because there's so many situations, I'll try to show maximum with minimum time wastage. So I'll talk about investigations and management. Coming directly to the management of meningoencephalocele nose, basically nasal endoscopy makes the first and foremost investigation. This is done after we have done a clinical judgment. Nasal endoscopy is done to make confirm our diagnosis and look into the nose for any other finding. Then biochemistry like CSF testing of nasal fluid or beta-2 transferrin testing if there is a CSF leak associated. Many a times there may not be a CSF leak in cases of congenital this meningoencephalocele. Imaging makes the most important part of the investigations, and it has both craniofacial CT and MRI hands in hands. These two are to be performed together. We cannot do with only one modality. So both modalities are to be performed together. CT for CT, we do high resolution CT scan. CT cisterno is not required because that is for small sized leaks, whereas the leak is, this defect is so very visible with the meningoencephalocele. So high resolution CT scan is done with 1 mm cuts. Overlapping cuts can be done in sagittal, axial and coronal planes. Sagittal becomes very important because it shows the exact size of the defect, which is usually much smaller than the size of the meningoencephalocele. So sagittal forms a very important part. So it is done, the CT scan is performed for pre-operative planning and assessment. Planning for any case of CSF meningoencephalocele is very important. Oh, shit.
Ma'am, you can go ahead. We can
I
see you
know.
and we can
Is
hear
it
you.
going, the light and sir, light has stopped.
It's
Give me
fine,
1 minute. I have a, just a minute. Light is gone on my side. I may not be able to show further. Just wait for a minute, huh?
Sure, sure.
So I'll talk about this high resolution CT scan. It is done for the first preoperative planning and assessment, then for identifying the fractures and any bony defects, looking into the size and location of the meningoencephalocele. Basically, very important because location becomes very important, whether it is in the frontal sinus, ethmoidal sinuses, sphenoid sinus, because the management is totally different from all these three sinuses. Then it can also tell us about any pneumocephalus or hydrocephalus associated with the meningoencephalocele. And if there is an intracranial abscess, I keep getting such cases because we have got a very good neurosurgery wing and they keep sending patients. I got one with the frontal sinus abscess with meningoencephalocele. So these cases, CT scan becomes very important, but it is not good for detecting any intracranial components in meningoencephalocele. And for this UCT, I'm showing this is both the right size. This is congenital meningoencephalocele from the foramen cecum, but here it lying medial to the middle turbinate. Here, this is post-traumatic. It is lying lateral to the middle turbinate. So all the treatment is altogether different for both the situations. So CT is a very important tool for us to make our diagnosis and confirm our diagnosis. MRI is equally important because it tells about the content of the meningoencephalocele. We do T1 and T2 weighted sequences again in sagittal, axial and coronal planes, along with the flare in certain situations. Why we do MRI? It is for the perioperative planning and prognostication, how we are going to do about how to counsel a patient after doing this MRI. This basically delineates the location of meningoencephalocele, and what better it can do from the CT scan is characterizes the herniated sac based on size, content, and status of the herniated neuroparenchyma. Because the brain in the sac is functional or not functional, that is very important and guides our treatment. I'll show you through MRI what it means. It also identifies associated intracranial malformations and also done for detecting congenital cases of CSF rhinorrhea or identifying areas where the dura is thin. So this is MRI. You can see the herniated content through osseous defect. the size is small, meningoencephalocele is so big, but the gliotic brain will show hyper intense on T2, and that brain which is non-functional has to be excised, whereas if there is a functional part of the brain, we never excise that, we only reduce it with the help of a bipolar cautery up to the defect and do the repair. So MRI becomes very important. Surgical techniques, we all know, are the extracranial, intracranial. Intracranial is for neurosurgeon, extracranial 90% times or 95% times extracranial techniques are required with best results. What it is, closed endoscopic technique or open osteoplastic technique, which is for posterior, superior, far lateral meningoencephaloceles in frontal sinus. So not telling about much about the intracranial because time is only 20 minutes. Extracranial endoscopic approaches, I have divided it into 3 categories. How I form and I do, I am sharing with that. If the skull base defect is up to 9 millimeter, which is less than 1 centimeter, I use combination of underlay or overlay techniques. Here, what I do, there's a small meningoencephalocele. We bipolar cauterize it and reduce it up to the level of the defect. Then bony rim of the defect is reached. Mucosa around the leak is denuded up to 5 millimeter. Then gently push free tissue graft into the defect, which for me is most of the times fat. Then place a fascial lata second layer over the defect and expose bony margin, and then it is sealed with fibrin glue, and it is supported with grafts, layers of absorbable and non-absorbable packing in the form of Surgicel and the Merocel. But if the size is between 9 millimeter to 3 centimeter, gasket sandwich technique, which I learned from respected Keertane Saroli, is my favorite. And I use that technique, but I may be adding any vascularized or non-vascularized flap over it, seeing the situation. So if it is I've shown 2 pictures, if there's a functional part of the brain or non-functional part of the brain. If it is functional, we reduce it with bipolar cautery. If it is non-functional, we excise this part. What the steps are next is elevate dura intracranially around this defect. Then we take a first layer of fascia temporalis, fascial lata, which should be bigger than the size of the defect. It is placed over the defect, and then a piece of cartilage bigger than the size of the defect is placed over the fascia, and it is pushed in a way that a collar of fascia remains out of the defect in all directions. So it is lying almost extradural. So then over that, I will place either a non-vascularized flap in the form of this fascial lata or a vascularized Hadad flap over that, seeing the size of the defect. Then comes the skull base defect localized in the sphenoid and frontal sinus. Slightly different approach is done for endoscopic technique. After reduction and excision of the meningoencephalocele, what we do is we can remove all the mucosa in the sinus and fill it with fat, and over that I can keep fascial lata layer supported by fibrin glue and Surgicel. Though literature has a different alternative for this, they say if the size is small, we may not require to obliterate the whole sinus, but because it is close to so many important cranial nerves and vessels, I tend to obliterate the sinus after repairing the defect. So coming to first, I'll show one technique in detail and then the rest of it small videos. This is case. I'll come directly to the case only. Is of a 2-year-old boy who presented with left-sided nasal mass without any history or presence of CSF leak. The nasal endoscopy revealed a pale pinkish mass occupying the anterior and superior part of the left nostril. The diagnosis of congenital intranasal meningoencephalocele was made on the basis of CT scan and MRI finding. The CT scan revealed a defect of around 8 into 9 millimeters in cribriform plate medial and anterior to the middle turbinate, along with a big mass filling the anterior part of the left nostril. This was confirmed on MRI, which delineated the herniated non-functional part of the frontal lobe through the cribriform plate defect, confirming the presence of meningoencephalocele. This sagittal view of MRI is showing that the meningoencephalocele usually herniates through a very small defect in cribriform plate, and it can misguide the surgeon regarding the size of the defect. The management of such cases is always surgical, and the surgery is divided into 2 parts. First part is clean excision of the meningoencephalocele, and second is repair of the defect in cribriform plate. For transnasal endoscopic excision of the meningoencephalocele, a 0-degree 2.7 mm nasal endoscope is used. And the important thing is that at each attempt during surgery, the instrument is introduced first, followed by endoscope to visualize the surgical field, because dimensions of nose is so small that it cannot accommodate both the instruments together. This is the left nostril of the patient. Decongestion achieved, meningoencephalocele visualized. It can be seen occupying the anterior and superior part of the nostril. Very slowly and gently, with a bipolar cautery, the meningoencephalocele is being cauterized. In such a small nose, it's many a times quite difficult to use instruments. So we have to keep manipulating and try to use the bipolar cautery with the finest tips. Care is to be taken to avoid bleeding when cauterizing the brain tissue, as any bleeding vessel can get retracted back into the brain and may lead to intracranial complications. So any smallest bleeding point should be cauterized well with bipolar cautery. The meningoencephalocele can be seen occupying the upper part of the septum and the roof of the nose, and the middle turbinate can be visualized in the background. Stroke by stroke, the whole meningoencephalocele is electrocauterized. Once the meningoencephalocele has been cauterized completely, the defect in the cribriform plate is visualized and exposed in its whole circumference. This step is quite difficult and should be performed with a lot of caution and care, as it is a small nose with a narrow corridor, and manipulating the bipolar cautery is quite difficult. The small residual part of the meningoencephalocele is also cauterized with a fine bipolar cautery. Once the meningoencephalocele is completely cauterized, the bony defect in skull base is traced. The exposure of the bony defect in cribriform plate is in progress. The repair of defect in this case is performed in 3 layers by gasket technique. The 3 layers of repair used are fascia, cartilage, fascia. After exposing the bony defect completely, the dura is elevated intracranially around this skull base defect. This step is performed to create space for placing the repair layers. The next step is to elevate or lift the mucosal layer around the big defect to bear the surrounding bone at least 8 to 10 millimeters on each side of the defect, because we have to place the repair layers. Once again, the circular knife is passed around the defect to make sure that the dura is elevated completely intracranially around the skull base defect. Now, a septal cartilage graft is being harvested to be used as second layer of the repair. The facial atta graft has already been harvested to be used as first and third layer of the repair. The first layer of facial atta size of the defect is placed over the defect. The second layer of repair is with cartilage graft, which has already been harvested. It is pushed inside along with the facial atta in a way that after the cartilage is tucked in, a collar of facial atta remains outside the defect in almost its complete circumference. In this case, after repeated trials, the cartilage was not settling in, which means that the separation of dura intracranially from around the defect is not complete. So both the grafts were taken out and a circular knife rotated all around the defect intracranially to achieve complete separation from dura. Many times it may not be easy to do so, so take your time, be gentle, because we have to perform it perfectly well. So if you need to take them out, again, do the procedure, do that, because the seal should be perfect. Once this step is complete, the repair is started again. First layer being facial atta, bigger than the size of the defect is second layer is cartilage piece, bigger than the size of defect is placed, the sleeve of fascia all around. The third layer is again facial atta, bigger than the size of defect, is kept over the two layers, and it also covers the bare bone around. The fibrin glue is pushed at this stage by lifting the third layer to complete the seal. The long strips of Surgicel are placed and glued there with the help of the fibrin glue. Finally, a small piece of Merocel with a suture tied to it, soaked in antibiotic ointment, is placed to cover the site, followed by a full length of Merocel nasal tampon placed in the left nostril. Post-surgery, 3 weeks, the surgical site looks like this when the healing is still in progress. 2 years post-surgery, the CT scan is showing complete clearance of meningoencephalocele and nasal endoscopy is showing complete healing. So this was a small defect according to me. Now this is another case where there's a post-traumatic meningoencephalocele which is involving both the posterior ethmoids as well as the sphenoids. So the defect was quite big. I have taken a Haddad flap to cover over the sandwich technique to make the assembly clear and stable. This is this case. Left-sided post-traumatic meningoencephalocele. This is going into the sphenoid sinus. You can see this was a big oblong-shaped defect. So here I've taken Haddad flap. This is the inferior Haddad flap should be harvested in the start of surgery and pushed into the nasopharynx so that the vascularity of this flap is remained when we are doing rest of the surgical steps. This is the inferior incision, anterior incision, and the superior incision of the Haddad flap. It is based on the posterior nasal septal artery, which is a branch of sphenopalatine, and that artery has to be maintained for the vascularity of this flap. So once we take this flap, we push it into the nasopharynx. Because the CT scan, I could assess that this is a big defect. I need a vascularized flap over the gasket technique. So this is maxillary sinus, already performed sphenoid sinus. Whole of the mucosa has been removed because I'm going to obliterate this sphenoid sinus. This is the extent of the meningoencephalocele involving both the posterior ethmoids and the sphenoid sinus. So all the mucosa of the sphenoid sinus is out. First layer is with the fascia, as I've already shown you. It should be covering more than the size of the defect. Then pushing an oblong-shaped cartilage inside, as I showed in the previous surgery. And this is the third layer. Over that, I plan to keep the Haddad flap. For this, I am filling the sphenoid sinus with fat, obliterating the sinus, and then I will put a Haddad flap rotated there after putting the fibrin glue. So it is such a beautiful flap. Now I am 100% almost sure that it is not going to recur. So lies very nicely. Post-operative endoscopy showing flap in place. You can see it nicely. So you must tailor-make your procedures depending on the requirement of the case. Now dealing with the meningoencephalocele and the sphenoid sinus, slightly different. There are two varieties. One is when it is from the posterior lateral wall of the sphenoid sinus. The other is when it is from the lateral recess of the sphenoid sinus. For directly meningoencephalocele filling the posterior lateral wall, we have a paraseptal approach, going directly, remaining medial to the middle and superior turbinate, entering this is the left nostril, middle turbinate, superior turbinate, and this hypertrophic mucosa at the entry of the sphenoid sinus. The inferior part of the middle turbinate is removed, enter the sphenoid sinus, clear all the mucosa, reach up to the meningoencephalocele level. Here it was a small meningocele only, so reducing the size, reaching up to the defect. Defect usually is very small comparing to the size of the meningoencephalocele. So small size defect, filling the fat, half in, half out, putting fibrin glue, putting fascia over it, and then obliterating the sphenoid sinus for complete surety. This is called paraseptal. Here we don't disturb rest of the sinuses. We go in the medial approach parallel to the septum. Now here I am taking a pedicled middle turbinate flap to cover the obliterated sphenoid sinus. And when it is a meningoencephalocele from the lateral recess, basically it is from they call it Sternberg's canal, which is located in the posterior lateral part of the sphenoid sinus. This is the weakest area of the skull base, originating due to the defective fusion during embryological development, leading to meningoencephalocele. So this is this lateral recess of the sphenoid sinus, and approach is endoscopic, endonasal endoscopic transpterygoid approach by drilling the orbital process of palatine bone and medial pterygoid plate. To reach this area, we have to drill this out. So this is slightly different from what we did for simple meningoencephaloceles in the sphenoid sinus. Now you can see this case, there was a big meningoencephalocele filling in this sphenoid sinus lateral recess. Right, this is the left side, sorry. The middle turbinate has been trimmed already. You can see Now I will expose both maxillary sinus and sphenoid sinus. Sphenoid sinus has been exposed, and this is the maxillary sinus posterior wall. Mucosa is being taken because I intend to open the pterygopalatine fossa, cauterize the sphenopalatine artery. This is the orbital process of the palatine bone being removed. There's a posterior wall taken out, pterygopalatine fossa opened, sphenopalatine artery being cauterized. This needs to be cauterized if we need to reach there in the lateral recess. This is sphenoid sinus, this is lateral recess. So this much part of the bone has to be out to visualize the meningoencephalocele properly. After bipolar cautery, we will remove rest of the bone close to this base of the sphenoid and a bit of pterygoid plates. Now you can see the meningoencephalocele there. There's a clear-cut bone differentiating the lateral recess from the sphenoid sinus. So I don't intend to obliterate rest of the sphenoid sinus. I have taken out mucosa in this part. I would rather take out mucosa of lateral recess only, not disturbing the mucosa of the sphenoid sinus. So I will obliterate only this much part. The mucosa where we oblitate has to be 100% out. Not even a single speck of the mucosa should be left to avoid any mucocele formation in the future. So all this mucosa is out. Meningoencephalocele cauterized. This is the gliotic non-functional part of the brain that is to be out. Filling it with fat, fascia, and obliterating the lateral recess with the fat only. You see, I have not disturbed it. It healed really well because sphenoid sinus keeps open. Lateral recess is only obliterated. Fascia fat. Nicely healed. Post-surgery, 3 months. Absolutely clear area. And this is the last one. Extracranial approaches, open osteoplastic technique when it is involving the meningoencephalocele is involving posterior, superior, or far lateral table of the frontal sinus. We cannot reach, and I don't believe in doing draft type 3, second one, whatever, because there's so much damage we do in the nose. If it is approachable through endoscope, do that. Otherwise, this is the simple plain method. We give a brow incision which is not visible after surgery, few days after surgery. Then we make a osteoplastic flap. Hinge inferiorly is raised by either drilling or drilling, and I usually do drilling of this flap based inferiorly. Then we open it up, remove all the mucosa from the sinus. Then first the defect, and then sinus is filled with fat and muscle. Flap is replaced back, and deficient. If there is if this bone is not available, in many cases there was post-traumatic damage to this bone even. So I use hydroxyapatite material to repair this. So this is one case for that. Right side superior wall gone. You can see endoscopically, I cannot think of reaching there. So this is the brow incision given. Drilling, these holes are for suturing after we have done the repair. Sinus has been opened. I have entered it. Now I can use endoscope or microscope, whatever. This is a meningoencephalocele, and there's the opening into the nose. So first I will remove every bit of mucosa in every nook and corner using the endoscope. Once I am sure that I have removed the mucosa, then only I will touch the meningoencephalocele. This is a very simple technique for, far lateral meningoencephaloceles of the frontal sinus. So this is it. Now the mucosa is out. Now this seems a gliotic part of the brain. I'll do bipolar cautery. If it is small, I'll do repair with fat and fascia. If it is big, I can use a sandwich technique. But this is absolutely clear and in control. So after reducing the meningoencephalocele, I am separating the dura from around the defect. Pushing the fat. Fascia. And then obliterating whole of the sinus with. Overfill it with fat because it shrinks by 1/3 its size. Again, residual fibrin glue, whatever we have, we push it here and place back this nicely sutured. Just see. And this is a post-surgery fat filling the whole of the sinus, nicely healed.
Superb. Thank you. Thank you so much, Dr. Madhuri. Fantastic. We don't have much time for questions, but a few points I would just like to make. May I, Madhuri?
Yes.
Now we use not beta to transferrin, but we started using beta trace protein.
Okay,
and
sir.
you compare the levels of the beta trace protein in the fluid collected with the blood level.
Okay.
The cuts that you take for the CT can be thin, even 0.3 millimeters now. And combining it with an MR T2 weighted image, you don't really have to do a CT cysternography now, because almost in 95% of your cases, you elaborated on that point, you don't do CT cysternography. But in that doubtful 5% of cases, rather than do a CT cysterno, if you do an MR cysterno, you're likely to get the delineation much better. It's far more comfortable for the patient. Whenever you're looking at the CSF, spontaneous defects, post-traumatic is different. But when you are looking at spontaneous defect, try to make sure that there is not a second defect coexisting, because it has occurred because of poor bone density, and you might find that you close one defect and a few weeks later the other one opens up. So look for more. And therefore, as the routine after surgery, we do a bone density, we ask them to take vitamin D3, calcium, and if it has been a spontaneous leak, ask them for their obesity problem to be reduced, because that is one of the commonest factors. Now, you've shown us using fat. We used to use a lot of fat to pack, but you will agree with me, I'm sure, that fat is very difficult to push inside. You push it and it keeps on coming out. So what we've now started doing, it is keeping a layer of fascia attached to the fat. So you take a combination of fat with fascia, or sometimes just the fascia loaded with fat, and it's much easier to push it inside than only with the fat. Try that. The fascia is much easier to use. Then over the repair, I usually, when you put Surgicel and the repair, I put a couple of layers of gel foam before I put the Merocell, so that when I pull the Merocell out, I don't accidentally give a pull on my repair, because the gel foam intervenes between the Merocell and your repair. We saw you putting that cartilage in the gasket form beautifully. If you slice the cartilage a little bit, it becomes more malleable and it is more. Otherwise, if you try to push the whole cartilage, sometimes if you push too much, it tends to fracture. So if you slice it, it becomes more malleable and it can go inside. And that last case that you showed, the frontal, was so beautifully demonstrated. The small little bony flap, you could see the defect and you sealed it beautifully. Just one word of caution to the people, that when you remove the mucosa, don't forget to remove the mucosa on the under surface of the flap.
Absolutely right.
Yeah, because otherwise you're likely to get. So that even the flap surface has to be denuded. But I congratulate you on an absolutely magnificent demonstration. Thank you very much. But we'll have to go on with the next. I think Guwahati has one question. We'll just take one question for you, because we'll have to have the next speaker on now. I can see him restlessly looking at the clock. Gaurav.
Sorry, I tried, but
No, you stuck to your time. You finished exactly in time. But Guwahati, go ahead with your question.
Good afternoon from Guwahati. Dr. Bani speaking here. I'd like to know, how do we ensure complete mucosa removal from the sinus? As you had said, it is very important to remove each and every part of the mucosa.
So the one thing, because of the shortage of time, I couldn't tell. What we first demarcate the size of the frontal sinus by taking an X-ray nose and paranasal sinuses, not the digital one. We take a cutout of that X-ray and place it here to open the window in the right place. Once the window is open in the right place, we are able to see, we can take a 0-degree endoscope or 45-degree endoscope or 70-degree endoscope, it should be removed in continuity. For removing the mucosa, there is a technique. Hold it with the forceps and just keep pulling slightly gently. And you will be surprised to see whole of the layer comes out without getting, broken in between. So we must, and as sir has told us, that the flap which I created should be also cleared of the mucosa. I go up to the frontal recess from this side and observe that I have removed every bit of mucosa before I go ahead and do the rest of the steps. So that is an important part.
Okay, thank you very much. Once again, a big round of applause for Dr. Madhuri Mehta, please.
Thank you very much. Thank you.
Thank you for coming to the program. As always, I think you're becoming almost a constant member of the...
I want to be,
But
sir.
I just wanted to tell you one headline I read in the newspapers today.
One?
In Times of India today, female surgeons get better results than male surgeons and have less. And I think we'll have a debate on this after some time. But this is in the Times of India front page today. That overall study done shows that female surgeons tend to get better results.
Thank you, sir. Thank
No,
you.
I don't agree, but we'll have a debate on that. We're waiting for Gaurav Medicari to come on now. Okay.
Thank you. Thank you very much.
Hello? Hello, sir. For last case, to replace the frontal bone, did she use any mini plates or just like?
I think she took suture. She showed us the suturing holes that she had made.
Sutures or mini plate, depending on how much the patient can afford. We do mini plate suturing, we put screws through mini plates also if we find that the bone is slightly deficient. Otherwise, we make the holes before surgery and do the suturing only. And that stays well.
I think when you're drilling, if you're drilling, you drilled in a slightly slanting fashion so that when you put the bone back, it fits well into the... You slant it from outside in, making a slight slope so that it fits in much better. Yeah.
Right. Absolutely.
Nishant, go ahead.
Yeah, so now we have Dr. Gaurav Medicari from Bangalore. He's a consultant rhinologist and skull-base surgeon at Medicari Super Speciality ENT Center. He's a program director, skull-base unit of SCG group of hospital. Also, he is a regional secretary of South and West Asia YOIFOS, and also he is a governing body member of AOI Karnataka. So over to Dr. Gaurav Medicari.
Yeah, Gaurav, we're waiting for you to share your screen. Gaurav, go ahead. Gaurav, can you hear me?
Yes, sir. Just 1 second. There's some issue with.
Somebody, can you unmute him from here or he has to unmute himself?
So he's already unmuted. He is connected on 2 devices.
Okay. Oh, because that sign there shows microphone is muted.
Yeah, so the audio has been connected to another device.
Okay. Yeah, we have your screen now. Go ahead.
Can you hear me now?
Absolutely, and we have your computer screen as well.
Okay, sir. Yeah. So thank you so much, sir, first of all, for this wonderful opportunity to speak on a topic which is not so frequently discussed. That is, central skull-base osteomyelitis. We've been having a lot of discussions of lateral skull-base osteomyelitis that have been discussed for a long time in patients who are elderly and diabetic. But this is a new emerging clinical entity that I have had the opportunity to operate on about 16 or deal with 16 patients in the last 2 years. And I thought that this should be, something that we should discuss upon. So if you want to define skull-base osteomyelitis, just like in Meniere's disease, you have definite, probable, and possible. Similarly, in skull-base osteomyelitis, we have definite and probable, which are the two definitions. So normally, whenever the patient has evidence of a skull base infection with local signs and symptoms, like for example, if the cavernous sinus is involved, then you might have diplopia. If the facial or the mastoid is involved, then the patient might have a facial paralysis. Along with this, if you have any imaging or scintigraphic features which are pointing towards bone erosion along with infection, and if there is also isolation of the pathogenic organisms, which could be either bacterial or fungal, then we go in favor of definite skull base osteomyelitis. Whereas in probable, the first 2 points are pretty much the same, but if you're using any tissue like probably an ear swab or a nasal pus swab to make the diagnosis of the pathogen, then we go in favor of probable skull base osteomyelitis. And in these patients, you might also see a positive response to antimicrobial therapy. So we have two types of skull base osteomyelitis. You have the normal ones, which we have actually discussed quite often. That is the typical or lateral skull base osteomyelitis, more commonly seen in elderly diabetic patients. They present with otorrhea, otalgia, along with hearing loss, and most commonly seventh nerve paralysis. Whereas the atypical or central skull base osteomyelitis, which we're seeing now, is more common in middle-aged people. They may or may not be immunocompromised. And if you carefully take a history, you'll see that their symptoms are much far ahead when you compare them to the signs, in terms that they'll complain of severe headache, atypical facial pain, and most often they will present with a sixth nerve paralysis, is what I have seen. So in lateral, you will obviously have an autogenic cause where it tends to involve the temporomandibular joint through the foramen of Huschke. It also involves the jugular foramen quite early on. The most common organism isolated here is Pseudomonas, and in immunosuppressed patients who don't have diabetes, you will see fungal infestation. Whereas in central, it is more often staph that you see, and fungus plays a very dominant role here. You will probably see more of Aspergillus and Zygomycetes, a group of fungi. The root cause here is a deep facial or a sinus infection, and it tends to involve the basis venoid and occipital region. Clivus, infratemporal fossa and carotid canal areas are involved more often. So there are 4 points which are essential to make a diagnosis of skull base osteomyelitis. The first thing is you need to have a very high clinical suspicion. And by this, I mean that the patient should fit into your profile of skull base osteomyelitis. Like what we already discussed, central versus lateral, you should have an elderly patient, diabetic, or whatever has been discussed. That patient has to fit into your profile to have a high clinical suspicion, or the patient might not be improving or might be relapsing with repeated course of antibiotics if you're talking about recurrent acute sinusitis. Second, you need to have radiological evidence of the infection. Third and most important is that you need to have repeated biopsies which are negative for malignancy. And fourth one, which may not be always possible, is that you need to have positive results for microbiological tests. So at least the first 3 should be mandatory. The fourth one, you may or may not get a positive result in these cases. So there are many ways of investigating. So there are 2 things which we usually do. First thing is the imaging. In imaging, we have 3 categories. The first starting step would be to do a contrast enhanced CT. One, because it's cheaper, readily available, much faster. So we do a contrast CT. In MRI, I'm going to discuss in detail CT and MRI, so I won't waste time there. In nuclear imaging, we have a couple of techniques which we can use. That is, we can use a gallium-67 scan. These are all radio tracer elements. We have a technetium-99. So these two, gallium-67 and technetium-99, you can combine with single positron emission computed tomography. That is called a SPECT. Other than this, you have the FDG, that is fluorodeoxyglucose. This can be a PET scan with CT or a PET scan with MR as well. So if you are using PET MR, you can also combine it with gadolinium to assess for activity of the disease. But the gold standard will always be biopsy. There are two characteristic features which you have to look for. The first one is it has to be negative for malignancy for you to say that this is skull-base osteomyelitis. Second thing is you may or may not get a positive microorganism visibility on the biopsy, but you should see polyclonal infiltration of cells, which means it should not be monoclonal, which means it goes against the diagnosis of lymphoma, because lymphoma is one of the key differentials when you're dealing with skull-base osteomyelitis. Other than this, there are some ancillary tests which are used. These are mainly used for prognostication or to assess if there is any recurrence of disease rather than to make a diagnosis of skull-base osteomyelitis. In these, ESR and CRP usually will be on the higher side if there is active infection and will tend to decline with treatment. But skull-base osteomyelitis patients usually we advise for a lifelong follow-up, and this is one of the key things that we always check for every visit, because if the CRP or ESR is again starting to go high, that means the patient is having another relapse, and that should instigate you to do a imaging protocol. Leukocytosis may not always be present. The reason being that these are usually immunocompromised patients, and hence we do not rely only on leukocytosis to make a diagnosis of relapse. So when we send biopsy, right, whenever we take a biopsy in these patients, at least at our institute, we usually send about 10 samples. So we use separate samples for bacterial staining, for bacterial culture, fungal special staining, fungal culture. We use it for histopathology. In histopathology and IHC, we take the samples from 3 different locations, not from the same location, 3 different locations. This is mainly to rule out malignancy. Along with this, we send 1 sample for flow cytometry for lymphoma, and we do keep 2 extra samples. One will be in formalin, one will be in saline. So just in case that, you need to go back and do something like, if none of these come positive, then you would probably like to do an immunoglobulin study on that sample or something of that sort. So these are the 10 samples which we usually at our institute send out. So let us just discuss the imaging modalities in a little bit of detail. So in contrast CT, it is obviously the initial evaluation. The most common thing that you will see that there will be submucosal soft tissue swelling. You may also see cortical and trabecular destruction of bone, and osseous demineralization can be seen. But MRI is much better at delineating the overall extent of disease. Why? Because it also gives you very good characteristic of the soft tissue involvement. So there are a couple of scans which we do in MRI. I think it's important that we mention this to our radiologist because otherwise you will not get the complete information. The first thing is you want to do T1 and T2 scans with contrast. You can also do a STIR configuration and a DWI, that is diffusion weighted imaging configuration. The other one which you want to do is a T1 fat saturation with contrast. These are the 5 scans which we usually get done. So on a T1 contrast, you will see that there will be enhancement of soft tissue along with infiltration of this soft tissue into bony spaces. But on a T1, you will see that the bone marrow is actually hypo-intense. Okay. Whereas on a T2 scan, you will see a hyper-intense bone marrow with enhancement, which is indicative that there is inflammation in this space, in the bone marrow space as well. And along with that, there will be enhancement of the surrounding soft tissue as well. The most important thing, especially if you are dealing with pterygoid osteomyelitis, is that you will see that there will be loss of fat planes, which is I will show you a scan where you can see that very clearly. So this is a patient who has aspergillus skull-base osteomyelitis. On a CT, axial CT, you can see that there is a mass, well-defined smooth mass in the nasopharyngeal space, which is extending laterally on the left side up to the carotid canal, nicely seen. And there is some indentation of bone on the scan. But if you do the same thing on an axial T1 without contrast, you will see that there is infiltration of the bone marrow in the clival area on the left side, which was not very clearly visible on the CT scan there. And you can also on a T1 fat saturated contrast see that in the paramandibular area or a retromandibular area, there is so much inflammation, and that is why there is enhancement in this area. So whenever you do an imaging, it has to be a combination of CT and MRI. we would not want to base our, our prognostication only on one of these scans. Nuclear scans, we can actually divide them into two groups. You have gamma tracers and beta emitting tracers. In gamma tracers, as I mentioned, you have the Tech99 MDP scan, that is methylene diphosphonate scan. So it relies mainly on increased osteoblastic activity. So if you have skull-base osteomyelitis where there is extensive bone involvement, this will light up very well. The other one, which I mentioned, is single positron emission CT. And the third one is the gallium-67. So the mechanism of action of gallium-67 is usually we do a white blood cell tagging for the gallium-67. And how it works is wherever there is excessive multiplication of white blood cells, it will actually go and attach to these white blood cells and allow it to be lit up on the scan. The only problem with gallium-67 is that you have to do a 3-phase scan and it takes a lot of time, and it will probably, you will only get the images about 48 hours after doing the scan. And that is the reason why it is not the #1 preferred scan as of today. But if you take in contrast with beta emitting tracers like FDG, that is fluorodeoxyglucose, which is also used for malignancies, if you have had a negative diagnosis for malignancy, then you can use fluorodeoxyglucose because it relies on increased metabolism. So it is not specific to skull-base osteomyelitis, unlike gallium-67, but it is much faster, it is readily available and much cheaper also when compared to a gallium-67 scan. So if you have a definite diagnosis that it's not a malignancy, you can, as an alternative, use an FDG, PET MRI with a CT as well to, make a diagnosis or even prognosticate the disease or to assess whether there's complete resolution. The other less commonly done scan is a sodium fluoride scan, where it relies on increased bone turnover to make a diagnosis. So here you can see this is actually, so what is DWI? I just want to take a minute to explain to you. So this is called as diffusion weighted imaging. So what you do on a diffusion weighted imaging is basically it's a T2 type of MRI, which means that water gets highlighted here. So the ability of diffusion weighted imaging scanning is to assess whether water molecules can move around in that said area where you want to examine. Now, if you have a tumor, so basically a tumor is nothing but an uncontrolled multiplication of cells. So you have more number of cell walls, which means that the amount of movement that the water molecules can do becomes restricted when you have a tumor. Whereas when you have inflammation, you have more edema, which is basically more fluid. So the amount of movement that water molecules can make on a DWI imaging is much more. So we say that on DWI, if there is no restriction, that goes in favor of inflammatory process or infective process. Whereas if you have restriction on DWI, that means it goes in favor of tumor. Okay. So the second image that you're seeing, the second, third, and fourth images are pretty much the same patient actually, one of our patients, where he had developed a clival bacterial skull-base osteomyelitis. So the first image you are seeing is actually a technetium-99 SPECT scan. So it will show up as a hot spot. Once we started treatment, after about 4 weeks, we did the second scan. This was a gallium-67 scan. We purposefully did a different type of scan just to assess whether there is any difference in the way we can see the, the lesion. But you can see that it's quite good and more specific to skull-base osteomyelitis. And also you see that there is a decrease in the activity. That means that the treatment that you're giving is actually working. So this way, nuclear scans can actually be used for assessing response to treatment. The last scan is actually again a axial fused gallium-67 SPECT scan, where you see that almost all of the hotness on the scan is completely gone. At this point of time, you can actually step down the patient from IV antibiotics to oral antibiotics. So the diagnostic dilemma that you will have in skull-base osteomyelitis is predominantly with regards to malignancy. So in skull-base osteomyelitis, you will have a well-enhanced and a full soft tissue contour, but you will not have destruction of facial planes. Like between two muscles, the facial plane will not be destroyed. This is different from loss of fat planes. Okay. So, and the second problem that you have, second feature that you have on skull-base osteomyelitis is that the MRI will be far ahead when compared to the CT scan. So these two things are negative on the in a malignancy, wherein in a malignancy there will be destruction of tissue planes, but you will see a well circumscribed tumor in majority of the cases, except if you have a condition like adenoid cystic carcinoma, where it becomes very difficult to differentiate the tumor from skull base osteomyelitis, in which case biopsy is the only way forward. The second thing that you want to observe is that in skull base osteomyelitis, in a lot of cases, I have seen that the mucosa gets spared. But in a tumor, it is not necessary that the mucosa has to be spared. So I will show you some videos where you will be able to see this very well. So I have a record of about 16 cases, and these were the risk factors that we had in our institute. Majority of our patients had diabetes, the second most common group. Because I work in a cancer hospital, we used to receive a lot of patients who had chemotherapy and became immunocompromised and developed SBO. Bone marrow transplant recipients, again, we do have quite a few of them. So cardiovascular disease is another important risk factor. Now you might wonder how cardiovascular disease actually affects, and causes skull base osteomyelitis. So in majority of these patients who have cardiovascular disease, they have small vessel ischemia as well. And that becomes the problem with in these patients, and they have a tendency to go in for skull base osteomyelitis. Patients who have received previous radiation therapy are also at a very high risk, because radiation basically reduces blood supply to that localized area, and that also can cause skull base osteomyelitis. And lastly, the lowest number of patients that I had was immunocompromised status, which is basically neutropenia or HIV or any of these sort of conditions. Now, initial presentation is actually very, very important in these patients. In most of our cases, we had headaches or facial pain. This is for central skull base osteomyelitis, where they were present with intense headaches and facial pain, which was out of character of sinus problems. Nasal congestion and discharge. Now, if you are getting mucopurulent discharge, then that is something that you need to be careful about. In these patients, even if you swab it, you might get something positive, but that doesn't necessarily mean that that is the only organism that is positive in these patients. In the bone, you might also find fungus also, which may be present. So it's better you do a guided biopsy rather than just taking a swab. Cranial nerve involvement was another thing that we saw very commonly in our patients. Most commonly, it was the sixth cranial nerve which was involved. Other than this, the patient might have some periorbital swelling or facial swelling, especially along the cheek. If there is involvement of the roof of the maxilla or infraorbital nerve areas involved, then this might be possible. So in about 6 cases, we had bacterial organisms which are isolated. We had most commonly in the nose, you find Staph aureus. Out of this, one patient had MRSA, which we had to again treat very aggressively. You have to do an MRSA eradication program for them, which means they have to apply mupirocin ointment in a couple of areas, that is ear, nose, thigh, rectum. These areas, they have to eradicate MRSA, and this program goes on for about a month's time. And they have to use a special medicated shampoo to take bath every day. And they should not scrub the skin. They have to only massage it. If you scrub, the bacteria gets entry into the skin. The second most common organism we had was Pseudomonas, followed by Acinetobacter. We had mixed growth in about 4 cases, and we did not have any growth in about 3 cases. Of these 3 cases, 2 of them are not doing very well. One patient actually passed away. We did not get any growth, but he was 94 years old, so he refused surgery. He refused a surgical guided biopsy as well. And he was not able to get admitted to a hospital, so he passed away. The second one, we did treat him very successfully. This was about a year ago. But now we are seeing a relapse where it has involved the atlas, and it has also involved the opposite side petrous temporal bone. So now we are forced to again go back in and take a biopsy from the petrous apex, and hopefully this time we get a positive growth. The third patient without growth is doing quite well. This was treated with presumptive, medication. In 9 cases, we isolated fungi. So you can see the first, picture which you're seeing is actually Pseudosporium. This is Aspergillus fumigatus, Aspergillus flavus. The fourth picture is Rhizopus. This is Zygomycetes, and this is Dematicious fungi. So these are the common organisms which we isolated in our. Like I said, in central skull base osteomyelitis, it is more of fungal than of bacterial. There were some cases of mucor as well, but I've not included them under this category of skull base osteomyelitis, because I would prefer to separate that group and call that mucormycosis as such. So one of the most common and challenging areas that we do come across is in infratemporal fossa extension. Now the problem here is that it's a very vascular area. Not only that, it's a very fat-rich area. So as I had mentioned, you will see that there is zero fat planes in the infratemporal fossa here. When you compare it to the opposite side, you can actually see a very nicely defined fat plane, and the muscular architecture is very well defined. In fact, you can also see this thing of the IMAX, the internal maxillary artery. And here the IMAX is present, but it is completely compressed and part of it is also devascularized. Now, this turned out to be Aspergillus skull base osteomyelitis, but in this patient, we also had Pseudomonas. Now, it is important for you to understand that Pseudomonas also has microangio-invasive properties, and that is why it is one of the most commonly isolated organisms which are seen. So, in fact, in these sort of cases, you will see it looks pretty much similar to, mucormycosis, but when you do the study, it will not yield mucor growth. In fact, we yielded Aspergillus in these patients along with Pseudomonas. In another patient, we also had involvement of greater palatine artery. Again, this was a case of rhizopus actually, where there was involvement of greater palatine artery and a large amount of the pterygoid base and the pterygoid bone itself was completely necrosed. So here we had to do an extensive debridement in these cases to achieve good outcome. Now, one important thing that you always should do is if the patient is complaining of symptoms which are out of the scope of a simple sinusitis, then you need to look beyond the sinus. Here in this scan, the first thing that springs to you is that you are seeing a double density on the MRI here in the left maxillary sinus, and the same thing on the axial scan. But if you carefully observe, you will see that in the retromaxillary area, if you compare with the opposite side, you can see the medial pterygoid plate here and the lateral pterygoid plate. But on this side, there is complete destruction of bone. Okay, and there is not yet, the fat plane is not yet destroyed here, but there is destruction of bone. This goes in favor of skull base osteomyelitis. So you have to keep an eye out on areas outside the sinus also. So this is one thing as ENT surgeons which we may not be doing, and this is something we should inculcate into our practice, especially with the rising number of diabetics these days. So this is how that patient will actually look like. So you can see here that there is a lot of pus in the maxillary sinus, and you know, when you flush it out, to your surprise, you will see that the mucosa may be absolutely normal. So this is one of the characteristic features that you'll see in skull base osteomyelitis, is that it is not necessary for the mucosa to be involved for the underlying bone to get involved. So it is important that you do this study on the scan. You may not find it when you're operating unless you expose the mucosa and check the bone underneath. Okay, so that is something that we need to pay attention to, and it's important that you collect all this, the secretions. So we have a container which gets connected to our suction. So whenever we, flush, it is always with normal saline, and when we suck, it gets collected into that container, and then we send that container specifically for testing. So this is a very interesting case. This is a young chap. Actually, he's completely immunocompetent. He does not have any comorbidities. He complained of very severe headache. He, in fact, even attempted suicide. That's how bad his headache was. He had left cheek pain, and he presented with diplopia and left pigment. As you can see here, you can see that the left eye is actually not moving in the lateral gaze. It is moving in the medial gaze, but it is not moving very well in the lateral gaze. So the suspected site of bleeding here, you see the clivus, because that is one of the areas where the Dorello's canal passes through close. The second area could be at the level of the cavernous sinus as well. So this patient actually had involvement of the cavernous sinus on the left side, as you can see here. This is again a case of fungal skull base osteomyelitis. The whole bone, if you see the architecture on the right side, you can see that the pterygoid architecture is very well preserved. The basisphenoid architecture on the right side is very well preserved. But if you see the basisphenoid on the left side and the basic pterygoid areas, these are completely destroyed by this fungus. There is some infiltration into the cavernous sinus and medial temporal lobe dura as well. So this is something that requires surgical, clearance. And when we did do a good surgical clearance, this is what it was looking like before. This is what it is now. Just 3 weeks after a good surgical clearance and putting him on posaconazole, he had very good clearance of disease. And you can see actually in the present scan, I unfortunately didn't have it on my laptop again, but the disease is completely cleared. In fact, it's not even say that this patient had disease on the new scan which is done. So it is a very rewarding surgery, and that is the reason why very aggressive surgery is so important in these patients. So here we have a patient here where there was extension of disease into the foramen rotundum. I'll just go back here. So you can see I'm actually drilling very close to the foramen rotundum there. And what is pulsating is actually the medial temporal lobe of dura. This is one of the most critical areas where, we can actually check for disease extension. You have to be very careful when you're doing this drilling at the level of foramen rotundum, because just above the foramen rotundum, you have the cavernous sinus. So the cavernous sinus is an inverted pyramid with the apex pointing towards the foramen. And when you're drilling, it makes sense to actually put a piece of marrow cell into this foramen rotundum. And we can also drill over that marrow cell so that we don't damage or accidentally slip onto the medial temporal lobe of the brain. Now, this area, actually, if you trace it backwards, it will take you to the trigeminal nerve or the Meckel's cave. So here, because there was a mixed infection in this case, so we had actually Staph aureus along with fungal infestation in this case. So whenever you have fungal infestation, surgery becomes the mainstay of treatment in these kind of cases. So this area where I'm actually operating now, if you go a little deeper, so this infestation has been identified on the MRI before. So when you open up this space, now we've actually cleared the disease of all fungus. So you can see that there is pulsation on the right as well as the left side. So the pulsation on the left side is nothing but the cavernous carotid artery, and the pulsation on the right side, what you're seeing is the medial temporal lobe of the brain. So this is actually one of the most difficult areas. If you have fungal disease, to clear it out in this area is actually a little challenging by the endoscopic approach, but it is definitely doable and it can be done, but you need a little bit of caution when you're doing it and a little bit of experience. That's about it. So one of the most common conditions that you will see in central skull base osteomyelitis is primary involvement of the clivus. So usually the patient will tell you that they have headache, which is predominantly in the occipital region. And you have a patient who appears a little toxic, complaining of occipital headache. It would make a lot of sense for you to do, and if it is not resolving with antibiotics, makes a lot of sense to do a contrast CT and an MR scan as per the protocol we discussed, because this is what the bone will look like to you when you open the sinus up. So the whole of the clivus in this case was actually completely necrosed. And again, here it was a mixed flora that we got. In fact, we had both Acinetobacter in this case along with Staph aureus, and we had Aspergillus fungus as well. So we had three organisms against which we had to initiate treatment here. So this was a polymicrobial case, and we had to initiate different modalities of treatment as well in this case. That is antifungal as well as antibacterial. So the same case you can see, the important thing is you have to drill out all the way until you start to see some normal tissue here. So if you see, there is still no normal tissue that we are seeing. And I would like to show you that you have to, sorry, here, this is the one. You have to actually drill out until you can expose the clival dura completely. In fact, you will see that, the clivus will actually flake off. So all you have to do is just go behind between the dura and the bone. And if you just pull this bone anteriorly, you will start to see that the whole bone starts to flake off. And that gives an indicator that this bone is actually quite devascularized and weak. And this bone becomes the nidus of infection if it is not taken out completely, because it is not vascular. Now you can see once the bone is out, you can see some fresh blood coming into the picture. And that is a very healthy sign in these sort of cases, so that now if you initiate your antifungal or antimicrobial therapy, then the result will be much better in these cases. What you're seeing, the pulsation here, is actually the posterior cranial fossa dura which has been exposed. So that is the postcranial fossa dura which has been exposed, and that is what is pulsating in this case. So you might also see some patients who look very bad. In fact, this is a patient who had actually developed central skull base osteomyelitis. There is a clivus, infratemporal fossa, roof of maxilla was involved, but it started spreading. So he was on initially he was only on IV antibiotics. He had refused surgery. But later on, it went on to develop into petrous apicitis, and from there, he developed lateral skull base osteomyelitis as well. And later on, we had to do a combined approach for him, that is endoscopic as well as lateral skull base approach. And this is what he looks like as of today, completely recovered from his condition. So it's like I said, it's a very rewarding, procedure. With regards to management, we have medical and surgical management, and both of them have their place. So if you have culture-driven approach, that is, if you have a biopsy which is positive or culture that is positive, and if it is purely bacterial, then your medical management is extremely good today. With the newer antibiotics which have come into the picture, they give you fantastic results, and you may not really require surgery. If you are not able to isolate the organism, then at least at my hospital, the clinical, the team leader for our skull base team, osteomyelitis team, is actually a infectious disease specialist, and what he prescribes is a combination of levofloxacin and clindamycin. If you have, and every patient, if you get swabbed in the thigh and the rectal area, this is to assess if they have MRSA. Every patient we do this, and if they come positive, then we start them on IV vancomycin. Now the treatment will go on depending on their gallium, on their PET scan, and the step down only happens after we stop seeing hotspots on the scan. And when we step down, we use ferropenem, which is a new drug now. And the reason why we use it is that it's got very good gram-positive cover and also gram-negative against aerobes and anaerobes. So all three categories of organisms are actually covered, and it forms a fantastic step-down therapy. In fact, the previous patient that I showed you, this patient, he was on step-down ferropenem for about 3 months post skull base osteomyelitis treatment, and he has done fantastically well. A lot of these patients are doing well now. Surgical management is very important. If it, in fact, it improves survival if the skull base osteomyelitis is secondary to fungus or mixed infections. And whenever you operate, if you have decided to do the surgery, make sure you are as aggressive as possible. Do not leave any, dead bone or dead tissue behind, because that will defeat the purpose of your surgery. And if you are dealing with purely bacterial cases, then you may not really need to do debridement. You might just need to do a biopsy in those cases. So complications in skull base osteomyelitis which lead to death are quite often very common. The most, so the one patient that I told you who had developed, who died, he had mycotic aneurysm actually, and it progressed quite rapidly. I think within a span of 2 days, he died. The cause was initially not known, but when we saw the scans, the patient got the scans later on, and there was an aneurysm which was very obvious. The hospital people had actually scanned him and figured out why, but the patient was not informed of the cause. That was what the problem was. So aneurysm, stroke, meningitis, these are some of the common problems that can happen in skull base osteomyelitis, and you need to have a watchful eye for these things. And that is why repeated scanning is very important in these patients. So this is our skull base osteomyelitis team. Like I mentioned, our infectious disease specialist is the team leader here. We have a microbiologist, pathologist, me with doing the skull base work, a neurosurgeon. In radiology, we have a full team where we have diagnosis, nuclear medicine, interventional. We have an endocrinologist for all our diabetic patients, a clinical pharmacist who monitors dosage for every patient and also assesses for any complications. And of course, we have our medical social workers and nurses who do a fantastic job as well. With that, I would like to thank my team as well as Dr. Kirtane sir and ALKEM for giving me this wonderful opportunity to address you all and share my 2 cents of knowledge on skull base osteomyelitis. Thank you so much.
Gaurav, thank you very much for a very comprehensive coverage of the subject. Maybe in one of the future meetings, we'll ask you to show us a case, where you've done the surgical dissection, because it's very fascinating that the area which you're working in is so inaccessible that we would love to, watch you demonstrate that.
Yes, sir.
So hopefully in one of the new sort of next workshops. So please get one ready for us.
Yes, sir, sure. Surely.
And I think we have exhausted your time, so I don't think we're going to have questions because the panel discussion is now waiting.
Okay.
So once again, big round of applause for Gaurav.
Thank you, sir. Thank you so much.
Thank you. And now we want Satish is on already. Yeah, so Dr. Satish Jain had to go away to Dubai for some emergency case that he was called in for, so he sent his apologies, but he's going to present from there. So, Satish, are you on? And I don't think anybody needs an introduction to Satish Jain. I mean, everybody knows one of the most amazing ENT surgeons of this century, I think. Amazing.
Good morning, sir.
Satish, lovely to hear your voice. We're all eagerly waiting to hear you.
So nice to see you, sir. Always like this. Always, you create an atmosphere for teaching and training. And this is one of the best examples. And thank you so much, for involving me again in this academic activity. I'm really indebted to you. I'm indebted to the team ALKEM for being in forefront of this academic trail in otolaryngology in our country. So good morning, everybody. It's a matter of privilege and honor for me to be invited by none other than Kirtane Saab and the team ALKEM for giving this, sharing my thoughts on this. Since I'm traveling abroad, so I'm not presenting live, though I am with you live. So I am presenting one of my recorded presentations on JNA, and I'll be live throughout for commenting. Feel free to interrupt for any questions, for any suggestions, or anything you want from me. So let's connect. Dinesh ji, can you connect presentation, please?
Clinicians for many regions, and the biggest of them is the bleeding. We all know this is a benign tumor of the nasopharynx. Though it is benign, yet it is locally invasive. The thing which scares the surgeon is the vascularity of the tumor, and it typically occurs in young adolescent males. These are 5 characteristic features of these tumors, and since bleeding is a concern, the reason is very obvious. The tumor itself is composed of vascular tissues, vascular channels with intermittent fibrous stroma, and the vessels are just endothelium lined. They're not having a thick elastic or the muscular layers to contract to control the bleeding. That is the reason they give uncontrollable hemorrhage, and that's what the concern to the surgeons. So in this talk, this talk will feature on certain issues about decision making on juvenile nasopharyngeal angiofibroma. There are lots of myths and controversies in the management of this tumor. So the first big challenge is reaching to a correct diagnosis, the appropriate radiological workup, the need for the embolization to reduce the vascularity. This is one of the most commonly practiced thing across the world. We'll discuss the pros and cons of that, whether to go by the open approach, the traditional one, and now the new endoscopic approach for last decade or more, which is more and more popular now for the regions, which we'll discuss. Recurrence, the so-called recurrence, this is a benign tumor, yet it can recur, but that recurrence, the so-called recurrence, is actually a residual tumor which can regrow. So the strategy to prevent the recurrences and a need in certain cases of radiation therapy will be a focus of the discussion today. So this tumor, as far as coming to the diagnosis, this tumor exclusively occurs in the young adolescent males. So like any young adolescent male presenting with nasal obstruction, history of bleeding, you put your endoscope and see a mass in the nasopharynx, it cannot be anything else than angiofibroma to your mind. It occurs immediately in your mind as juvenile nasopharyngeal angiofibroma. That is how clinically we diagnose it, and we refrain from biopsying such lesions for the sake of preventing hemorrhage, because this vascular lesion and we don't want that kind of hemorrhage from biopsy. So the diagnosis is again, confirmed by means of radiological findings. And this tumor has a characteristic radiological appearance, characteristic pattern of spread by means of you can pick up on the radiology. The tumor arises in the region of the pterygoid wedge here, and then it circumferentially grows to certain preferential areas like nasopharynx, pterygoid process, laterally, anterolaterally goes to the pterygomaxillary fissure into the infratemporal fossa, posterolaterally through the pterygoid process goes to the parapharyngeal space. Superiorly, it can go to the inferior orbital fissure to the orbit, and then superiorly, posteriorly, it can go on from the orbit to the cavernous sinus, to the temporal lobe, and so on. That's how it creates more and more problems. So that's how it is diagnosed on radiology with certain characteristic findings. So the question comes that what radiological investigation need to be ordered to begin with. So by and large, the first radiological investigation to be ordered or should be ordered is a contrast enhanced CT scan, which gives you a by and large picture of the enhancing tumor with certain characteristic preferential path of spread to diagnose as a JNA. Our philosophy is to not only the contrast CT scan, our philosophy now is to order a CT angiogram, which not only gives you the benefit of the contrast CT scan, the information which you get from the contrast CT scan, more than that, it gives you information about the vascularity of the tumor. That is most important. The vascularity information you get out of the CT angiogram is very, very important in decision making. I hope my CT angiogram is being shared on the screen now. May I know? Can you see my CT angiogram shared on the screen?
Yes, we can see it very clearly.
So when we order a CT angiogram, what we recommend clinicians to look at the CT angiogram yourself, because we don't only need the information of what vessel supplying to the tumor. More than that, we want the information that how the vessel is entering into the tumor. How many other vessels are going to the tumor? We all know most commonly as the tumor, once it starts growing, it gets exclusively its blood supply from the internal maxillary artery. But as tumor goes to the other areas, it acquires more and blood supply from the other thing. Like in the parapharyngeal space, once it grows, it acquires additionally from the ascending pharyngeal artery, it goes to the skull base, it acquires more and more vascularity from the internal carotid circulation. And that is a decision-making thing. For surgeons, we should know what are the vessels supplying to the tumor. Not only that, how the vessels are entering into the tumor so that you can take a call whether you can control that vessel beforehand, before you handle the tumor, so that you can handle it endoscopically or not, or that we have to go for the open approach. So this is one of the decision-making factor. And here, what I'm going to show you is how to read the CT angiogram for this particular purpose. In a very, very simple manner, I can go quickly, and then we'll go into details of this. See, this is the common carotid artery in the neck, dividing into the external and internal carotid artery. As we go up, see my cursor. These are a lot of branches arising from the external carotid artery. The facial artery, superior, the lingual artery, the ascending pharyngeal artery. And then this external carotid artery goes behind the angle of the mandible. See this? And divides finally into two terminal branches. See here, two terminal branches. This one is the internal maxillary, and this one is the ascending, the superficial temporal. So this internal maxillary is of concern as far as JNA is concerned. See now, look at this in a dynamic fashion. I am following this vessel. Internal maxillary, internal maxillary. This is the tumor in the infratemporal fossa, nasopharynx, nasal cavity. This is the pterygopalatine fossa, and this is my vessel. And see how this tumor and this vessel related to the vessel goes in the anterior part of the pterygopalatine fossa, being pushed anteriorly by the tumor itself, and go in the anterior part of the pterygopalatine fossa to supply this tumor. That is behind the posterior wall of the maxillary sinus, and that is an added advantage once you consider endoscopic approach, because in such lateral extension or approach is the endoscopic dankers. It's not that the medial part of the tumor which you can handle, endonasally. The concern is the lateral most part of the tumor with full exposure
and taking the vessel into control. What simply you can do? See this. This is the lateral part, lateralmost corridor part of the tumor here. What we see. We need to remove this medial wall of the maxilla and part of the anterolateral part to have a head-on exposure to the most lateral part of the tumor. Sometimes there is more lateral extension. You don't need to go far laterally in the linear fashion. You can mobilize the tumor in your field. But this is by and large the kind of exposure, head-on exposure you need to the lateral part of the tumor by the endoscopic dankers. And this you can simply achieve by this approach. What we want to know from this endoscopy, this CT angiogram, how the vessel is entering into the tumor. Many a times we have seen the branches of the vessel or vessel itself enter the tumor from behind and remain behind the tumor, particularly in revision and other situations, difficult situation, complex tumors. And then you have to think twice to take up the endoscopic approach before, because then to catch the vessel, to take the vessel in control endoscopically, you have to go through the tumor, and that is counterproductive. Our approach to the endoscopic surgery, which I'm going to discuss later on, is based on taking the vessel into control first before entering into the tumor. Because the moment you enter into the tumor, it will show what it is. It is so vascular, you can't control endoscopically the field, the surgical field, and then you can't manage the situation under vision. So the principle is to catch the principal vessel first. Many of the cases we are doing without embolization, which I'm going to share with you the reasons behind that, in what cases we embolize, what we don't. And in majority of the cases when we don't embolize, based on this fact that how the vessel enters into the tumor, we take a call whether we can tackle it endoscopically or not. So this is one of the most important factor. And this dynamic CT angiogram, which you can see on your console, see this, what I was saying, you can see 3D. This is my vessel which is entering into the tumor. See, this is the vessel. And if I want to see this vessel in all planes, I can see here how the vessel is, see this is the vessel here. Let me remove, this is the vessel here. And see how this vessel, at what point of time, at what level it enters into the tumor. This is how it enters into the tumor. So when you open the posterior wall of the maxilla to enter into the pterygopalatine fossa, actually in this coronal plane, when you see, you can have a fairly good idea at what level in the pterygopalatine fossa, what height of the pterygopalatine fossa, what anterior-posterior level. By means of three-dimensional dynamic CT angiogram, you can have a fairly good idea where exactly you are going to find the vessel. Like for example, in this patient, the vessel is here. When you open up the pterygopalatine fossa, you can get to know the height. See this? Let me again take this. See, this is the level of the heart palate, and I can see this vessel is roughly 1.5 plus centimeter above the level of the heart palate. So you can have a fairly good idea where to look for the vessel rather than blindly looking for the vessel and ultimately damaging it. So this is the beauty of the dynamic CT angiogram, that you get the complete information about the tumor, the extension, the same information which you get from a contrast CT scan. But more than that, additionally, you get to know what vessels are entering into the tumor. Like in this particular patient, see this is the ascending pharyngeal artery arising. This is the ascending pharyngeal artery arising, and this one of the branch is entering into the tumor from behind. See, there's small branches entering into tumor, but this kind of small branches entering into it, you can handle rather than handling a big branch. Though this branch is behind the tumor, so you can expect some sort of bleeding when you deliver the nasopharyngeal part. So that you have to be prepared. It makes you prepare that how much bleeding approximately you're going to have. And if you really need, you really expect more bleeding, you can arrange more blood and you can plan your way according to your experience. So this is one information. Second information about the diagnosis. For diagnosis, what we believe, the MRI sometimes helps you a lot. MRI is one investigation which helps you like, anything. Let me show you this, one of the CT angiogram and the MRI. This patient, see, this is, I told you, this is one of the most decision-making investigation. In MRI, one of the sequence, so like such tumors we get, many a times we get such tumor occupying the entire nasal cavity, nasopharynx, when the GNAs grow like anything. And you really do not know whether it is a GNA or not, because you can't take a biopsy once you suspect a GNA. And MRI certainly helps you in this regard. And one of the most important sequence of the MRI, that is called diffusion weighted MRI, is a bioimaging. Bioimaging in the sense, diffusion weighted MRI calculates the water molecule movement in the magnetic field. MRI is a magnetic field. So in those lesions who have a high water content will have less diffusion. Those tumors who have a less water content, more cellular, more nuclear cytoplasmic ratio, will have more diffusion restriction, and those are considered to be malignant or more likely to be malignant. Here, such tumors with no diffusion restrictions are 100% something you can rule out a malignancy in these. We have seen couple of patients referred to us with a nasopharyngeal mass in the child, assuming a JNA for surgery, and when we investigated with the MRI, found huge diffusion restriction and turned out to be malignancy rather than a JNA. So you can avoid such misdiagnosis by means of doing an MRI in those situations. Like for example, this tumor, this is a different situation. Just to give you a fairly good idea about the diffusion weighted MRI. See this patient who had this tumor. Yeah, this was the tumor. See, this was a malignant tumor. Why I'm saying malignant tumor? Look at the diffusion restriction. This rules out any benignity of the tumor, rules out JNA, rules out any other benign tumor. And this is one of the most important sequence pre-operatively when you are not supposed to take a biopsy to confirm or to rule out a malignancy. So this is second point in the diagnosis, which is sometimes very, very important. Third point in the diagnosis is the need for an open approach, or you to take a call between the open approach and an endoscopic approach. Our philosophy to take a call between open and the endoscopic approach depends upon a lot upon the CT angiogram, number one, and number two, the extent of the tumor, and number three, the vascularity coming from the intracranial circulation. See, once you're removing any tumor endoscopically, if the tumor is getting additional vascularity from the intracranial ICA or part of the intracranial circulation, if you try to avoid such tumor from below, it can lead to retraction of the vessel from above and can bleed intracranially and can be a disaster. So that is one factor. Second factor is the extension of the tumor. See, in endoscopic, in our series, majority of the cases we do endoscopy, except some example which I am going to show you, some situations. In endoscopic is not a contraindication for a big lesion. I tell you, any big lesion can be removed endoscopically, provided you need a space to maneuver your endoscope, provided you don't have a vascularity coming from the intracranial circulation. Look at this example. This particular patient had a huge tumor. Let me show you how big the tumor is. Now, if you want to take it endoscopically, you can, but see, look at the size of the tumor. Look at the, not only size, where will you maneuver your instrument? Where will you maneuver your telescope, instrument, the visualization? See, to begin with, the moment you put your endoscope in the nasal cavity is all tumor. You can't maneuver, and the principle in such tumors, because of the vascularity, the principle is to not to go into the tumor before taking the vascularity in control. Whatever embolization, whatever you have done, you are not supposed to go into the tumor directly to create hemorrhage, to give hemorrhage and to make the situation worse. So in such situation, see such a huge tumor where you don't have a space to even put your endoscope, these are tumors, I would say, are relatively where the endoscopy is contraindicated, to make your life so difficult, to make your surgical course more longer. Even if you do heroics, you would try to manage it endoscopically, try to segmentalize it, it is going to take so long. Overall bleeding is going to be so long, and such young children, see this 12-year young with so much of surgical time, with so much of blood loss is something you need to think twice before taking such a call. And second indication for endoscopy, see this particular tumor, it looks so good to remove by endoscopic approach. We have removed many such tumors by endoscopic approach, which has extended to the intracranial space. This tumor has a tendency not to invade dura in the beginning. So majority of these tumors are extradural. Now the challenge comes if the tumor acquires the blood supply from the one of the intracranial vessels, which I'm coming to, this is opening. I'm going to show you. See this huge tumor vessels. Huge tumor vessel, this is another, relative contraindication, because such tumor vessels are difficult to call. Even with the whatever good embolization you do, the embolization reaching to the microvasculature level is so difficult in such. This is like every fistula within tumor, which is most difficult. Now the interesting finding in this particular case, even such case we can take up endoscopically. What stopped us from taking endoscopic is, see this tumor which has gone intracranial to the middle cranial fossa, the region number 1. See this vessel, where this vessel is coming from? The middle cerebral circulation. If you have, see this vessel coming to the tumor, coming from the middle cerebral circulation, and if you happen to remove this tumor from below, avoiding this vessel would be a disaster. Second, see this vessel. This vessel is a branch from the MCA. This vessel is a branch from the MCA coming directly to the tumor. See inside the tumor. Such huge branches from the MCA coming to the tumor, to me, is a direct contraindication for an open approach. And in such cases, we add on the subtemporal approach to have a good exposure from below and up. You can remove the upper part of the tumor first, devascularize from the MCA branches, and push it down, and you can remove whatever you can play your game from below. Then you are pretty safe to do that, rather than playing everything from below, and that sometimes can be a disaster. So this is one of the most decision-making, a point when you take this call by means of diagnosis, by means of the CT angiogram. This is another interesting example. We were all set, looking at the MRI of the patient, we were all set to deliver this patient endoscopically. See this? This is the tumor. This is the tumor. This is a huge lateral extension, which is no way any contraindication to endoscopy. We segmentalize and remove in parts. And this is the internal maxillary branches. Now, as you go behind, this tumor was going to the orbital apex, and then laterally, this is the dura. This tumor was completely extradural. It looks like, so simple to deliver endoscopically. As far as the contraindications are concerned, looking like no contraindication in this particular situation. When we got a CT angiogram, the situation completely changed altogether. Now look at the CT angiogram of this particular patient. See, this is so important. You can avoid a big disaster by all these means. Now coming to the CT angiogram in this particular patient, if I reconstruct to the coronal one, see this coronal CT angiogram. Now this is the vessel. This vessel, see, this is the main MCA, is giving a huge branch to the tumor from above. If I try to bring it down from below, it can be a disaster. See the ICA giving huge branch to the tumor. This, to me, is an absolute contraindication for any endoscopic approach. If you try to do, this is something I would say a disaster, and for patient it is never safe. So our philosophy is to get a CT angiogram, see how the vessels entering into the tumor, to take a call whether it can be taken by open or endoscopic approach, whether there is a need for embolization. If suppose the tumor is limited where the vessels are coming from behind, we would take a call of embolization rather than going to the tumor and catch the vessel. Then another indication for open approach. Look at this patient. This was one of the most massive JNAs we have removed, and the simple regions, the decision making was not difficult in this particular patient. For the regions, I tell you, this is arterial. Yeah. So this particular patient, look at the tumor. This was tracheostomies. tracheostomy and see, just a minute, yes. See, this is tracheostomy and this was the tumor. This was the tumor and see how it is coming from the nose, nasopharynx, right to the facial soft tissues across the mandible and eyeball, skull base, intracranial space, and see the vessels, the branches of the carotid, the huge carotid-like branches passing, many such branches passing to the tumor. Let me take this MVP protocol to show you vessels much better. MIP sequences, yes. Now see this tumor with a huge facial extension. We followed each and every vessel going to this, and this tumor had a huge vascularity from the superficial temporal artery, which you anyway can't control by an endoscopy. This kind of a mass lesion, you can't control endoscopically for it. See the carotid artery, carotid and carotid-like branches passing through the tumor, many such branches passing, huge branches coming from the internal carotid, passing to the tumor is a certain contraindication. And the carotid since was 360 degrees submerged. We did open approach, we did DSA before, we sacrificed the main vessel preoperatively by means of coiling, and the cross flow was good and could be able to remove the tumor completely by a maxillary swing and the subtemporal approach. So you have to take a call, and there are certain open approaches we need to know in our practice so that we can take a call in those given situations. It's not that always that the endoscopy is the approach of choice. Open approaches do have their place in those conditions. We need to identify those indications in certain situations. So the workup is very important. As I mentioned about the angiograms, the need of MRI, the vascularity, see the diagnosis. You can actually see the vessel, how the level of the vessel when you take the internal maxillary in control. And this is the MRI angiogram. I can skip this. So coming to the bleeding aspect, what all you can do to manage the bleeding. See, as I said, there are many sources of bleeding to this tumor. This is a pure vascular tumor. The bleeding can come through the external carotid system, sometimes bilateral, and the principal vessel is the internal maxillary. And as the tumor grows further to the parapharyngeal space, to the roof of the infratemporal fossa and other areas, it can acquire some other vessels like coming from the ascending pharyngeal and the middle laryngeal. It can have, as you have seen, the branches from the internal carotid system as the tumor, invades the skull base deeply, and of course the venous bleeding, particularly from the pterygoid plexus and the cavernous and the other venous system areas. So there are three sources of bleeding: external carotid, internal carotid, and venous bleeding. Now, what does the embolization do? There are the list of maneuvers to reduce the bleeding overall during surgery. Embolization is the principal one which is being practiced across the world. Maybe pre-operatively, intraoperative embolization. There are so many methods to embolize nowadays, the newer techniques to embolize. Nowadays we have tried in few patients, besides coil embolization, particle embolization, glue embolization, and now we have tried in a couple of patients the onyx embolization. The cost is a limiting factor, but truly, if you ask me, the best of the embolization situation what you get from is the onyx. It's a liquid material, very safe, can't enter the dangerous anastomosis to the internal carotid system, pretty safe, and it can reach to the microvasculature of the tumor. If you embolize with the coils, you don't reach to the microvasculature level. Particles may not reach to the depth, and if you try to use smaller particle, then the chances of through the dangerous anastomosis to the internal carotid system are high. So there are limitations for so many things. But onyx is really good. The cost is a limiting factor. Along with that, the control hypotensive anesthesia coagulation we use, which I'm going to show in one of our few of our videos. Then other techniques you all know, flow seal surgery. There's so many things you can use intraoperatively to control the bleeding. So like these are the techniques of embolization. I'm not going into details, but there are certain advantages why people are practicing. The reason is one and only the reduction in the overall blood loss. You can maintain your visualization, reduce the need of transfusion more and more, and you can take care of surgically inaccessible arterial feeding vessels by completely embolization. This is one of the biggest advantages, I would say, besides the bleeding control. So overall operating time is reduced, your visualization is reduced, and you're more confident in removing such tumors, larger tumors, rather than having without embolization. But it is not all free of complications. There are certain concerns also with the embolization. Availability of the good embolization facility, the expert embolization team, the cost, sometimes the cost exceeds the cost of the surgery, particularly in a country like India, where cost is a big factor for poor patients. The risk of thromboembolism because of the dangerous anastomosis, you have to be careful. The intervention radiologist should be very, very experienced. The effectiveness is, as I mentioned about the embolization, reaching to the microvasculature level, which is very, very important. More than that, this has been studied through, I have gone through certain publications that people have studied the tumor margins. You know, without embolizing, when you go without embolization, your tumor is seen distinctly from your surrounding areas as compared to the embolized time where your tumor margins are difficult, they get collapsed, and sometimes this tumor, which has a tendency to, you know, enter into the narrow crevices and canal from the pterygopalatine fossa to here and there, and the tumor, collapsed tumor, can be sometimes difficult to identify, and you leave behind the part of the tumor, which is the major cause for the so-called recurrence. So overall, it has been, you know, published, the recurrences are overall high in the embolized patients as compared to the non-embolized. So the embolization is something not free of problems. And what you achieve by the embolization, you don't actually embolize the internal carotid system bleeding. If you have a vessels coming from the internal carotid, you know, system to the tumor, you practically don't embolize, and you have to face that bleeding. You have to prepare yourself with extra blood and other maneuvers to reduce that overall bleeding. Venous bleeding, you can't do anything by means of embolization. What you all achieve with the embolization is the bleeding from the external carotid system, and in those situations, the majority of the time, it is the internal maxillary which is the principal vessel. And once internal maxillary is the principal vessel and you have a CT angiogram, how it is entering to the tumor, what we do intraoperatively, rather than a pre-operative embolization without wasting time, energy and money into that, we go intraoperatively, go to the vessel first rather than a tumor by means of straightforward dankers. The vessel comes from lateral, catch the vessel first, intraoperatively devascularize the tumor and then remove it like any other tumor, rather than, you know, embolizing all patients. And we take the call of embolization upon based upon the various vessels coming to the tumor. Like such large tumor, which is a vessel coming from the ascending pharyngeal branch, which is a vessel coming from the middle maxillary, and those vessels, this is internal maxillary, which you can of course catch before handling the tumor. But these two vessels coming from behind you can't catch, and these are the ideal candidates for embolization, because to catch these vessels, you have to go through the tumor, which is impractical, that is not possible, and these are the ideal candidates for embolization, rather than, you know, indiscriminately embolizing every patient. That is something, a change in the surgical technique which we have been following and propagating. So this slide is about the categorization for the junior colleagues, whether they can handle these tumors according to their facility, their expertise. Tumors which invade the skull base, tumors which do not invade the skull base. This is how you can categorize them into various categories according to your competence to remove that tumor. That is something different thing to discuss here. Now coming to the endoscopy in the open up, we have already discussed during the CT angiogram part which patients which they don't do endoscopic. Majority of the patients will do endoscopy for the advantage, for the certain advantages. Not that the endoscopy is avoiding a scar is a big advantage. Any tumor or any procedure, if I am doing with the open approach with certain distinct advantage, I'll opt for that rather than endoscopy. So one has to have a advantage for opting for the endoscopy rather than simply avoiding a scar. And here You all know the illumination, the kind of illumination endoscopy gives. On-site magnification and illumination is the major advantage of the endoscopic system. This tumor has a tendency, as I said, to spread through the various fissures and canals and the hidden corners, which you can see through the endoscope much better with the wide-angle endoscope. And secondly, the most important thing for the so-called recurrences, the tumor has a tendency to invade the eversion system of the pterygoid and the sphenoid bone, which you can drill very well under endoscopic guidance, which cannot be achieved at that level by any open approach. That is the major advantage why we go with the endoscopy, not for simply avoiding a scar. But still, in the patient safety, point of view, we take a call of open approach in certain indications which I have already mentioned. Few words about the recurrences. The recurrences have many reasons, and the biggest one is the inadequate assessment and the planning. This is something I mentioned, and that's why I mentioned in beginning in detail about the dynamic CT angiogram, which gives you a lot of information about the tumor extension, vascularity, the various vessels, how they enter into the tumor. So that assessment and planning is the key. A fault in the assessment and planning can lead to a overall, failure. Marrow infiltration is one of the biggest reasons, particularly pterygoid and the sphenoid bone, that you need to completely drill away. If you happen to leave a smallest portion of the tumor, it can regrow to a bigger size. And those recurrences are, believe me, much more difficult to handle than the primary tumors. Then tumors having significant ICA blood supply, which you are handling, are more difficult to clear up completely, more difficult to ensure a complete clearance, and then the recurrence is imminent. Significant intraoperative bleeding is one of the factors where you can't identify about the tumor clearance 100%, and that is one of the source of recurrence. And surgical expertise, whatever, is very important. Whether you go by the endoscopic or open approach, one must be well versed with all this. And particularly for the endoscopic surgeon, I would say, even in this endoscopic era, endoscopy is the advantage. We must be well versed with certain open approaches in our practice in certain given situations, like maxillary swing, subtemporal, sometimes the lateral anatomy, and one of the midfacial degloving, and all these approaches one must be well versed in certain given situation. So these are the indications for the open approaches, particularly in the revision situations with encasement of the major vessels, particularly carotid arteries. This is the contraindication for any endoscopic approach, as you cannot handle the internal carotid laceration as effectively as compared to the open approach, and that is something contraindicated in many of our patients having complete encasement of the carotid. As I mentioned, we got the DSA done with a good cross flow. We got the carotid artery coiled from a few millimeter or centimeter proximal and distal to the involved segment, and remove the tumor from the carotid completely. That gives you an opportunity without lacerating the vessel, and so that is one of the way. Otherwise, in majority of the encasement situation, we go by the open approach. And if you have to, it is imminent to give a laceration, then it is better to avoid that and leave those particular patients most difficult situation for the post-operative radiation. Radiation is never a treatment of choice, but it is reserved for only those patients where the surgery can be more, something endangers the life. This is now one of the surgical strategy about removing the division of the tumor. See, in the present context, we have been able to remove more and more bigger tumors by endoscopy, and that strategy is possible by means of division of the tumor. See, this patient has a huge infratemporal fossa cheek extension. What we need to do is, you can't deliver this tumor as a whole. What we do, take the vessel in control first, divide the tumor at the lateral end of the nasal cavity or the medial end of the maxilla, deliver the medial part first through the oral cavity, acquire some more space to bring in the lateral part and deliver it separately. So sometimes this segmentalization of the tumor is an important, strategy to remove the bigger tumor. Sometimes which segmentalize into 3, 4, 5, 6. In a bigger tumor, we have done even 12 segments of the tumor to deliver such tumors. So before coming to the topic given to me on something to speak about nasopharyngeal angiofibroma. We all know juvenile nasopharyngeal angiofibroma is a big challenge to the clinicians for many regions, and the biggest of them is the bleeding. We all know this is a benign tumor of the nasopharynx. Though it is benign, yet it is locally invasive. The thing which scares the surgeon is the vascularity of the tumor, and it typically occurs in young adolescent males. These are 5 characteristic features of these tumors, and since bleeding is a concern, the reason is very obvious. The tumor itself is composed of vascular tissues, vascular channels with intermittent fibrous stroma, and the vessels are just endothelium lined. They're not having a thick elastic or the muscular layers to contract to control the bleeding. That is the reason they give uncontrollable hemorrhage, and that's what the concern to the surgeons. So in this talk, this talk will feature on certain issues about decision making on juvenile nasopharyngeal angiofibroma. There are lots of myths and controversies in the management of this tumor. So the first big challenge is reaching to a correct diagnosis, the appropriate radiological workup, the need for the embolization to reduce the vascularity. This is one of the...
Yes, sir. Yeah. Can you stop this now?
Yes, yes.
So this was about decision making. I'm not playing any video since this was a recorded one. So we can have some time for the discussion, for any questions if somebody has, or any suggestions or anything. I have got one question.
Questions?
I have got one question from Dr. Prakash Munka, sir, regarding the need of pre-operative carotid coiling. I mentioned, in the discussion, when the tumor involves carotid arteries circumferentially, particularly in the revision situation when it is more and more invasive. In primary situation, it is unlikely to be invasive. It grows by expansion. It can compress the carotid, but it rarely invades. But once it is invading or circumferentially encasing, the chances of carotid artery lacerations are very high, and it is not advised to remove such tumor without taking carotid under control. So like tumor is invading the cavernous sinus, tumor is invading intracranial structures around the carotid artery, get the cross flow checked first. If the cross flow is good, by all means, it is not 100% by any means, but yes, by and large, you can check. The young fellows have good cross flows. This tumor slowly grows, so it allows ample of time for the collaterals to grow. So majority of the time, you get a good cross flow when the carotid is compressed and it gets vascularity from the carotid. So in those situations, get a pre-operative DSA, confirm the cross flow, and then taking the patient attendance and confidence, you can follow this safer technique of pre-operative coiling of that particular segment of the carotid artery, little proximally and distally, to prevent laceration of this artery once you dissect the tumor. So this is one of the greatest indication, and we get many a times in the revision cases, we get that we need this kind of carotid coiling. And this is once the carotid is coiled, then it is pretty safe to remove the tumor from the carotid surface. You can literally peel off the entire tumor from the carotid surface with a coil inside. There is no flow inside. There is no chance of lacerating and giving hemorrhage into the carotid artery. So this is one of the indications. Any other questions, sir?
Sir, there are 2 questions. Guwahati Center, please. Can you put up your question?
Nice to see Kaushal and Dwaipayan on screen. Hi, guys. Hi, Dwaipayan. Yeah. Please, questions, Kaushal.
Guwahati. Can you unmute yourself?
Guwahati location, please unmute your mic. From the Zoom call, please unmute your mic, technical team. So
Hello. Yes, sir.
Hello, can you hear us now? Yeah.
Yes.
Question from Guwahati when a novice surgeon is starting to do these nasopharyngeal angiopharmamas, what is the recommendation of pre-op securing of the say external carotid artery before you approach the tumor as such?
Yes. So it has been, one of the methods used in the past to reduce the bleeding, hoping to reduce the bleeding. But external carotid artery, if you secure distally, is not going to have any impact practically. It's not an end artery. It has number of branches and anastomosis and all that. If you tie down the trunk of the external carotid, it is not going to have any significant impact on the overall bleeding. So the the impact will be maximum when closure of the vessel is as close to the tumor as possible. That's why in the embolization also, it's not embolizing the main trunk of the internal maxillary is going to have much impact. It is the microvascular embolization through the embolizing branches of the internal maxillary artery into the tumor, micro branches, that is more effective. So microvascular embolization is more effective. That's why embolization is a operator dependent measure, wherein the quality of embolization, the prevention of unwanted complication due to efflux of material into some other vessel, that is all dependent upon your competence of the intervention radiologist. So microvascular embolization is required, not the distal vessel embolization, and that's why the liquid embolization is now more preferred, which can flow down to the microvasculature rather than particles. The bigger particles cannot enter into the microvasculature, and that bleeding control is not very effective. So out of all that, the external carotid artery ligation is hardly having any role in reducing overall bleeding.
Thank you, sir. There's a question from Bhubaneswar Center. Dr. Mohapatra would like to ask.
Yes.
Bhubaneswar Center, please unmute.
Satish, sir?
Yes, boss.
Yes, sir. What is the incidence of female JNA? We are encountering such cases in recent days. And is the pathogenesis different from male?
JNA is a diagnosis. Pathologically, it is not distinct from any other vascular lesion. So, finding a JNA in a female is always a tagged pathological diagnosis, I would say, wherein you find a tumor having vascular channel, location in and around nasopharynx, and term JNA. The actual JNA with the classical characteristics of vessels, as I mentioned in the second slide, the JNA is composed of, a bunch of vessels, and those vessels characteristically lack the fibrous and the elastic layer, is never found in females so far. So whatever so-called female diagnosed JNA are never true JNAs. They are all vascular lesions looking similar to any other vascular lesion being found in, since found in nasopharynx and around and termed JNAs. They are not true JNAs.
Right. What other differential diagnosis immediate close to it so that we can approach or plan our surgery?
So, by and large, differential diagnosis I mentioned in one of the slides, even in the young males, patient coming with a mass in the nasopharynx, typical looking like JNA, to get a contrast CT scan done, it looks like a contrast enhancing mass. Many times we have seen MRI is decisive. MRI is always decisive, particularly the diffusion weighted MRI, which will clearly differentiate a tumor, a malignant tumor, or any other tumor from this fluid dominating vascular tumors. See, diffusion weighted MRI, characterizes the water content in the magnetic field. More and more water content will have more and more diffusion. Restriction and diffusion signifies some tumor which has more cells more nuclear cytoplasmic ratios, and it is unlikely to be JNA. So diffusion weighted MRI is classical in differentiating from other tumors, other diagnosis.
Right. Thank you, sir. Thank you.
Pratish, thank you very much for a fabulous session. We know that you had to run away outside because you were invited for some surgery, but you took time off for us. So really grateful to you that you could do this for us. It's always a
Thank
great
you
pleasure
so much,
listening.
and all thanks once again to Kirtne sir for planning such important academic sessions, and big thanks to you, sir, for involving me once again. Thank you so much.
Okay, God bless. Thank you. I think we need to have the panel discussion started immediately now. And we made a very clear announcement outside. Lunch will be served only after the panel discussion is over, so don't anybody go out.
You have to mute. So thank you.
So we have a very interesting panel discussion. Dr. Sunita is going to be a moderator for this panel discussion. The topic is the latest updates in the allergic rhinitis. So I request Dr. Sunita to please come and introduce the panelists as well.
Now I would like to invite Dr. Chandrakant and Dr. Harsh Kumar as chairperson and moderator for the next session.
I am Dr. Sunita Shukla, the panelist for today's session, and I like to invite my colleagues and friends here. We start with Dwaipan. He's a busy consultant at Kolkata. All the panelists are, I think, well known, so I will just call out to them. Dr. Subir Jain sir from Indore, leading allergy specialist. My teacher, Bachchi madam, HOD of Nair Hospital. She is my teacher. And my dear friend Nitika Gupta from Jammu. At the outside, I would like to thank my mentor and my teacher, Kirtane sir, for giving us this opportunity. As you can see, over the ages, I have changed so much, but sir is still the same. So I feel he's still the evergreen young idol of ENT. And I call him the Devanand of ENT. So with this, thank you, sir, for everything. When we were residents and ENT was a learning curve. Every time when I used to see sir right from tonsillectomy, FES, cochlear implant, he made things so simple for us that even the most difficult of the surgical things, it was a butter easy step for us. So I hope with this panel, we do the same for our audience over there. And my whole team of esteemed panelists will help us in that. So we have decided to do a case presentation, the way we see a patient in our clinic and what are the challenges we face and how do we approach it so that we can give the best recent update, put it into practice and help our patient in getting a best quality of life. So this is about a young 21-year-old female. She has a history of sneezing, running nose, which was occasional since childhood. Now it has increased a lot and it is throughout the day, and perennial, that is most of the time of the year. She has nasal block with polyps, cough, shortness of breath, which is occasional. She is on nasal spray twice a day, double dose, 2 antihistaminics, can't sleep or study well. She has a history of nasal polyp which was operated twice. And now she also has a family history where the father has allergy, some skin issues, and he's taking fexofenadine daily for the last 20 years. She was given the option of surgery for the nasal polyp. This was the third time, which she refused, and hence she was referred to me for opinion of allergy and can we do something with the total hygiene and some other blood test reports. So let us split this history now step by step and see how can we approach this patient. So coming to the diagnosis, to my esteemed panelist, what are the cardinal symptoms of allergic rhinitis? Does this history itself is self-explanatory?
Can I speak?
Yes, ma'am.
So basically a history of rhinorrhea, especially regular with episodes of sneezing, not just one sneeze, a lot of sneezing, and a nasal block, itchiness in the nose is characteristic of allergic rhinitis, whether seasonal or perennial.
Absolutely. And since this patient was also operated twice, I think, is this the diagnosis which you all will suggest in this patient? So it is allergic rhinitis with recurrent nasal polyps. Now, adding to the history, the patient has a postnasal drip. So do you think postnasal drip is a feature of allergic rhinitis? And how do the patient explain it?
I would label this patient as a patient of allergic chronic rhinosinusitis with nasal polyposis, and probably this is a central compartment atopic disease because the patient has classical allergic rhinitis history. There is recurrent polyposis. If you get a CT done, you will see this is a characteristic case of central compartment atopic disease.
So
and
we will
yes,
come
these
to
patients.
the investigation. Now we are only sticking to the history.
So
We
in
have not
history,
seen even
yeah,
the nose
the
of
history
patient.
per se says that the patient has an operative history. You have examined and seen nasal polyps there, and she has cardinal history of allergic rhinitis. So definitely, this is a case of allergic rhinosinusitis with nasal polyposis, and definitely these patients have PNDs.
Yeah. These last points, the postnasal drip, dry cough, shortness of breath. So these are all indicative of lower airway disease also. So at the time of taking history, we must actually
You have
ask
started
all
late,
those
so
patients
we do
whether they are having all those
felicitate
symptoms of
our
congestional dyspnea or all those things are present or not.
officers.
Because right now we all know this is unified airway disease. We cannot actually take all the responsibility on our own. So if we can suspect from the history that we are having the lower airway disease, then we can take help from the pulmonologist colleague also.
Absolutely. So maybe we change the diagnosis now to allergic rhinitis with recurrent nasal polyp with bronchial asthma. And as Dwaipan rightly said, this is the united airway disease, or we call as the one airway, one disease. And this is the concept which we are following. Though we are ENT, we should understand this is finally one airway and the patient can present in both the ways. And it's a very common dictum to say that there is no wheeze without sneeze. So I think everyone agrees on this. Yeah, because the nose is the gateway to the respiratory passage, and most of the time any patient who has any lung hyperreactivity, the nose will be involved in this. So coming to the classification, this is one of the old classification which we have used in the few years back. Do you agree with this and do you still use it?
Please, you go ahead. No problem. Yeah, definitely. ARIA classification, that is practically perfect.
I'm talking of this classification. This is not ARIA classification.
It's
So
a
this is a very simple seasonal and perennial.
yeah, seasonal, perennial, depending upon the duration also. That's perfect.
So maybe I will add one more aspect, perennial with seasonal exacerbation. This is also very commonly seen. So do you still feel this old is gold, or you have, I think we just added. So we come to the latest classification. During the presentation, we will explain what we are doing and what we should be doing depending on the recent updates. And all these updates which I have quoted is evidence-based medicine, international guidelines which have been posted post-2020, that is post-COVID. So the recent ARIA guidelines is this. I think we all use this in our clinical practice. Any input on this? Why this is better than the old classification?
Actually, ma'am, this actually helps us to delineate the patients and categorize these patients. Once you categorize, you actually know what is the intensity of the symptoms, and that actually helps to make a complete diagnosis, because you know that a patient who has moderate to persistent AR needs to undergo testing, needs to undergo step-up treatment. And for step-up treatment, you need to actually zero in the causative, the culprit behind the allergic rhinitis. And once you do that, you need to decide on the symptom basis, on the VAS scoring, whether this patient would step up, require AIT or not.
Absolutely. It will help us in the management. Now we'll see how it does it. Yeah.
Yeah, definitely, same.
Okay.
As per this classification, we can plan the treatment depending upon intermittent, then persistent, mild, moderate. Totally step up, step down.
So
gradually we go ahead. Yeah.
So now we change the diagnosis to persistent, moderate, severe allergic rhinitis with recurrent nasal polyposis with bronchial asthma. This is a provisional diagnosis just based on the history. Do you think we are still missing something here?
Can I add something?
Yeah, please.
Yeah, as we all know, this is the ARIA classification, latest classification, that is intermittent and persistent and mild to moderate to severe. Both the varieties may be mild to moderately severe. And we can actually plan the treatment accordingly. But nowadays, the prevalence of allergic rhinitis is gradually increasing, and we may have different characteristics of the presentation. So, along with these things, some phenotypic classification, that clinical classification, sneezers or runners or blockers, are sometimes very useful, because by actually categorizing the patient in this category, we can customize our treatment.
Yeah. So I'm coming to it. So till now, with the history, this is our diagnosis. One thing which I think we are missing clinically is the quality of life of the patient. Though in the ARIA guidelines, they are talking about sleep, daily activity, bothersome symptoms. One thing which we ignore in our clinical practice is smell. And this one question is very important, and why it is important we'll see in the few slides. So do you, any of my panelists here, take some parameters for assessing the quality of life? There are some hints on the screen.
Definitely quality of life is totally impaired when the patient suffers from severe persistent allergic rhinitis. All other parameters are also disturbed, and that's why this is included in the top 10 diseases which causes disturbance in the day-to-day life.
Yes,
that is by the WHO. So definitely this is something very, very important.
Yeah. So do you use any questionnaire in your clinical practice when such a patient comes?
Yeah, definitely. Yes. There's a detailed list, around 3-page history taking, but the detailed questionnaire is there, and we ask each and everything to the patient.
Ma'am, you want to add something?
No, we also have a detailed questionnaire. We ask a lot of questions, but also the stresses on the quality of life, the smell, the taste, which usually is lost out when your patient is talking to you. Even the patient rarely tells you that he has lost his sense of smell. He will say, I have a choking nose, I have an obstruction in the nose. But when you ask him, he says, oh yes, I can't smell also, so it's very important.
The guidelines ma'am has mentioned, all these guidelines these days, they categorize the symptoms, and the step-up treatment, these days we follow according to the ARIA recent update and the post-2020 update. We need to phenotype the disease, we need to endotype the disease, and we need to upgrade the treatment depending on the phenotype and the endotype of the disease.
Absolutely.
Also, we need to take the VAS scoring of the patient, because our treatment step up and step down would completely depend on the VAS scoring of the patient.
Yes.
So the patient, when it arrives the first visit, the consequent visits, you have to take a VAS scoring of the patient, so as to decide whether you need to upgrade the treatment or downgrade the treatment.
I totally agree.
I think this SNOT 20 or SNOT 22 questionnaires are very effective, because there are 4 sets of symptoms are there: nasal symptoms, oral symptoms, then behavioral symptoms and sleep. So by actually giving this questionnaire to the patient at the initial stage, at the starting of the treatment, and with the follow-up period, then we can actually assess the progress of the disease and the effectiveness of the treatment.
Yes, absolutely. So in my opinion, SNOT 22, though it is very good, it is very good for colleges, medical college, where you have your residents to do lot of paperwork. And clinically, if you have your own setup, VAS is very good. Why so? We'll see in the future slides also. And I think the importance of visual analog score is, even if you have an illiterate patient, you can ask him whether you are the green happy face or you are the angry red face as per the symptoms, and he very well tells you, and this will help you in further managing the patient. Let's see how it is done. So coming to the other history was a family history of allergies where the father has this allergy, and this we call as the history of atopy, where the patient has some allergic genes which are passed on to him. So what is your opinion on atopy, and is this important for a ENT person to know whether there are allergies in the family?
Definitely. It plays a very major role as soon as patient is there and we take the detailed history. And if there is a family history, definitely that particular patient is at high risk. And if even in the moderate to severe cases, we go for allergy testing in those patients where there is a strong family history.
Yes. So we go by this chart. If both the parents have the chances of allergy that the patient is having increases to more than 50%. These all small points which we are discussing will help you in making decision making about the treatment of the patient, and hence these questions. Now, this patient was referred for the opinion of allergies with a total serum IG level of 288. So do you think this is relevant for the diagnosis of allergic rhinitis? Total serum levels.
I get total serum. I hardly get total serum IG levels. People usually come up to me with reports of total serum IG, where a lot of people have reportedly normal total IG levels, and they have been consulted at various clinics and mentioned that they are not allergic. I have patients with severe allergies, severe persistent allergic rhinitis, severe allergic asthmas having normal IG levels. So it is a kind of, you cannot rule out allergies with total IG, but yes, definitely it helps you at times to prognosticate the disease, and you can monitor definitely with it. But if you ask me it as a diagnostic criteria, it is not.
Absolutely. Any other opinion? So for diagnosis, we definitely don't need a total IG, but yes, maybe it becomes an add-on if you're doing only pure allergy practice, because there is this recent study which tells that if the IG level is high, the chances of polysensitization becomes very high for that patient, though it doesn't have any role in diagnosis the disease. I think everyone agrees to this. No role of total serum IG. Okay. So coming to the clinical approach, now this was all on the history, we came to the diagnosis, we understand the family history and so on. So coming to the examination, do you do anterior rhinoscopy? Or is it a lost art to
Always,
DNE
always.
or
Working in
CT scans?
a medical college, always anterior rhinoscopy is the first. And in fact, even on anterior rhinoscopy, you can see features of allergy. As you will see the turbinates which are engorged, they are pale in color, the mucosa is pale. And then you move on to endoscopic examination.
Absolutely. So for allergic rhinitis with polyps, I think a simple anterior rhinoscopy is enough to make a diagnosis. As madam said, auscultation.
Ma'am, every single patient in my clinic who comes up with the history of allergic rhinitis, I always auscultate the chest. I've seen a lot of patients having unnoticed wheeze there, and they are hardly aware about they just have difficulty breathing. They are only concerned about their nasal blockage. They hardly know about their lung involvement. So it is it is kind of mandatory to check the chest of the patient. So just merely using a stethoscope for 1 minute will help you out to diagnose such things.
I think I agree. As ENT, we don't use stethoscope, but after coming into allergy, and if the patient gives you something, many times you will pick up these wheezes, as Nitika said, and that is very important. Coming to diagnostic nasal endoscopy, now we are talking about this case only. Do you want to do a DNE for this patient?
No.
Okay. We all can have difference of opinion, because anterior rhinoscopy, you can see the polyp and all. Okay, fine. I'm not getting more into lungs because this is a ENT audience, but there's something called a spirometry because this patient had features suggestive of asthma, as Dwaipan was saying. Spirometry is always an option. And then we'll come about these two important tests later. Now, this is the DNA of the patient. This was given to me by the ENT surgeon. I have not done this DNA. And anything you want to do, do you want to take a biopsy at this stage? This is a recurrent polyps, third time. Do you want to do something?
Definitely not a biopsy, because we know the previous histopath report would show you polyposis. And if suppose you feel that something looks abnormal, for example, an inverted papilloma will not look like this, or rhinosporidiosis will not look like this. So if
Yes.
it is this, it is definitely polyps.
Yes. So for diagnosing AR with polyp, you don't need a biopsy. But in such cases, you are in a research center, medical college, whatever. And if you are doing a biopsy, this biopsy can be pre-op and post-op also. One thing which we have to see for is tissue eosinophilia, and the significance will see why we have to do it. Otherwise, a biopsy is not required in such a case.
One thing very important is whenever you even send your samples, you are operated a case of nasal polyposis, do mention that you have to get the eosinophil count per high power fields. It's very, very important. It helps you to phenotype the disease, and actually it decides your treatment plan post-operative. You can avoid recurrences if you know the phenotype and the endotype of the disease.
Yes. So this is a very common practical problem, that though you know that you have to see eosinophils, your pathologist doesn't know. So please mention this on the form, that please look for eosinophils, and then only you can title it as tissue eosinophilia. So coming to what Madam was saying before about the phenotypes. Now, initially it was only AR with polyps, but now we have come to the phenotypes. So is this phenotypic classification important? And what's the recent update on this? Does it help you clinically in deciding management of the treatment? Has it changed your practice? Madam, since last maybe, this was not there when we were residents? Yes. This
So
is
most definitely it will help you to diagnose the condition better, and it will change your management because you will know exactly what to give the patient depending upon what phenotype he belongs to.
Yes.
Most definitely.
So the commonest phenotypes with the nasal polyps are the eosinophilic mucin, which we all know how it looks on the surgical table, and the AFRS also. The aspirin exaggerated disease we don't see so often in Western India, but the other two are very common. Now coming to another recent aspect about the endotypes. Someone was mentioning endotypes. So what is this endotype and why it is important in this case?
You need to actually know whether this is actually allergic or it's a non-allergic endotype. So once it is allergic, your treatment profile change, and when it's non-allergic, your treatment profile changes. There are separate reasons for allergic endotypes developing recurrences, and there are separate reasons for non-allergic endotypes developing recurrences. So you can actually prevent recurrences in an allergic phenotype, endotype, merely by starting the AIT. AIT will actually drastically reduce your patient's chances. You have done an excellent FES, but if a patient is not post-operatively managed, the allergies are not well managed, this patient has a very high chance of developing the polyps again. And just diagnosing their Th2 cascade, diagnosing the Th2 inflammation, you identify whether the patient has IgE predominant disease, you can start AIT and you can prevent recurrences.
So here you can see on the slide, the center, the highlighted one are the Th2 disease, and the lower one is the Th1. Whenever you take a biopsy, the Th1 will be mostly neutrophilic, whereas the Th2 will be eosinophilic. And to understand it is a Th2, you need only two investigation. One is CBC, which will show you eosinophilia, whether it is a tissue eosinophilia, a nasal smear eosinophilia, or a blood peripheral eosinophilia. And the second thing is the Ig level, which is usually raised. Otherwise, we don't ask for Ig. So that is how you understand. Now there is a type 3 also. We are not getting into all those cascades. So in our case, our patient, as we can see with the CBC and all, it was a type 2 inflammation type. Now, this is just, I have put a slide that please tackle the lower airway also, do a spirometry, send it to your pulmonologist friend, where you will see an obstruction with reversibility. And now coming to the diagnosis of the allergen causing the problem. Now you know this is an allergic patient. So the most important test, do you agree that skin prick test is the gold standard diagnostic method?
100%.
I think there is no doubt on this. Thanks to lot of WhatsApp messages and groups and all, there were a lot of difference of opinion but since my esteemed panelist has said okay to it, I'm not going further into those questions. So coming to the diagnosis, history is self-explanatory. For testing, SPT is the gold standard. Why? I want to explain this so that there is no doubt about regarding SPT. This is the skin, and when you do a skin prick test, you are activating the mast cells present in the skin layer. When you do a serum specific IgE, you are actually measuring the free circulating IgEs in the blood of the patient. And these are not getting activated. You are just collecting the blood and finding the number. And similarly, when you do a challenge test, it can be any challenge test, whether it is a nasal challenge, food channel, bronchial challenge, there also you are activating the mast cell. So actually for food allergies and all, the oral challenge is the best. But for nasal allergy, because we don't have the system to do all those things, skin prick test becomes the best because it is easily available, can be done by anyone, it's very cheap, there is no risk of anaphylaxis and so many other good things about skin prick test. This is a small video of how we do skin prick test. A small drop of, anyone want to explain this, Subir sir?
Basically, what skin prick test, what you are doing, when I started my practice, it was with a 26 gauge needle. Then came 3 mm lancet, and now today it's a 1 mm lancet.
Yes.
Absolutely painless procedure. Even I do kids 4 years, 5 years, and they are just smiling, no pain, no bleeding. And I assure them, don't worry, bacha. Absolutely, there won't be any pain and not even a single drop of blood will come out. And that's so fantastic. Immediately gives result within 15 to 20 minutes. So that is the gold standard skin prick test, and it's 100% fantastic way to go ahead.
So I think the slide proves it, where we are doing the testing. And in kids, we don't do everything. The more experienced you become, your number of allergen testing goes down. Anyone who is practicing allergy understands what I'm saying. So what are the commonest allergen which you see in your practice?
Yeah, this is the most commonest allergen in the skin prick test, the dust mites. And I just want to add another thing regarding skin prick test, why it is so important, because ultimately at the time of skin prick test, if there is presence of sensitized cells, that means already there is exposure of the allergen, and that leads to specific IgE from B lymphocytes, and that is attached with the mast cell causing sensitized cell. So when we are doing the skin prick test, then again this same allergen, and this allergen is just enter into the beneath the stratum corneum and attached with the sensitized cell, causing this degranulation of the mast cell, and reaction can come within 15 minutes. So this is the direct test, and we can monitor the result of this test on our own. So when we want to send our patients for the serum IgE, specific IgE test, we have to depend with some diagnostic centers. So it is always better to control the result or to monitor the result on our own if we want to actually carry our allergy treatment. So this is the importance of skin prick test, and usually the most commonest nowadays are the indoor allergens, and among the indoor allergens, these mites are most important.
Absolutely. So that is a point well taken. Many times you will see reports from other centers, someone has done it, where everything is positive, and then the patient is asked to avoid everything, including important food items. So just because you have got a wheal and flare doesn't mean the patient is allergic to it. Sensitization is an immunological process, and you have to again go back to the history, cross-check it with the patient, the symptoms and the period, and then you say whether the patient is allergic or not. So allergy is a clinical thing and sensitization is an immunological reaction. The second commonest allergen is pollen. Anything you want to explain about pollen and why it is important for an allergy specialist or an ENT to know why this is important or that area?
So as far as the pollen profile goes, you need to know the pollens of your own, your flora fauna of your particular region. It is not that you're going to test. We have ample number of pollens available throughout the country. You have to have the knowledge of what is the flora fauna in your region and in the region of the patients, where if you get patients from outside. So in my region, there is a dominance of Cynodon dactylon or Bermuda grass as far as the grasses go. But I have an additional grass which is Typha augusta, which is not there everywhere. So as far as the tree pollens goes, Holoptelia is very common in my region, which is not there in south. So you need to know the allergen profile of your region. You need to know the pollination period of that particular pollen, because you will correlate the patient's history of seasonal exacerbations with the pollination period of that particular pollen. And let's suppose if a patient comes up that he or she has exacerbations in the month of February, March. I know what pollen I am going to test for that particular patient. I'm not going to test a complete arrow of 40, 50 pollens. I'm going to test very selectively those particular pollens who are dominant in the months of February and March. So that reduces your number of allergens to be tested. So you actually have to know the flora of your region. That will help you to reduce the number of allergens you're going to test. And it will also help you to identify the clinically relevant allergen, which you're going to further ask the patient to.
Yeah. So this history becomes important when we showed the slide of seasonal and perennial air. When you get whatever pollens, that is the time when that history becomes an add-on to your new area classification. So coming to the management, how do we manage this patient? Once you know what are the things patient is allergic to, there are 4 pillars. One is allergen avoidance. The first is obviously the diagnosis, then the avoidance of the allergen, symptomatic medication, because whatever good diagnosis you do, but if you can't give relief to the patient clinically, it is a disaster for the patient. So first give a pharmacotherapy, we'll come to that, and then go for some disease modulating treatment and change the quality of life of that patient. So anything else you want to do separately?
Patient education. Absolutely most important thing is patient education. The moment patient enters in, we listen to the history. We just conclude that yes, this patient is suffering from allergic rhinitis. You have to convince that patient better to control your allergic rhinitis here. Otherwise, in 35 to 40% of the patients may go to the lungs. 20 to 25% patients, sinusitis, nasal polyposis, 20% otitis media with effusion. So you have to educate to the patient that please try to understand the severity and the gravity of the situation, what it can further result in the future. So that is most important.
I totally agree with it. Anything else you want to add? So education, no doubt, you have to make the patient aware, because allergy is such a new thing.
Why this is important? Because for treating not only allergic rhinitis but CRS, we need partnership between the patient and doctors, because this is not a short-term treatment. So the compliance is important. So prior to the starting of the entire therapy, it is always important to discuss all the options, and it needs a prolonged treatment. So in the starting period, if we can convince by educating our patient, most likely the compliance will be better and the end result will be much more.
Yes.
For the same, I have made patient education videos and they are available on YouTube. My YouTube channel is there that contains videos about basic knowledge about allergic rhinitis in layman's language, not for doctors. Then how to use intranasal corticosteroid nasal spray and how to use immunotherapy and how it is effective. So patient education is most important.
Yes, we are coming to it. So I think we all were following this ARIA guidelines for managing the patient. And as the ARIA guidelines is very clinical, as the severity of the disease is increasing, you go on adding your pharmacotherapy. As I think there is no doubt about it, but ARIA mentions that once the disease has become persistent, whether it is mild or moderate severe, immunotherapy has to be added to it. So let us see what the guidelines are and how they talk about it. What about the antihistaminic, the non-sedative generation 2? I think that is the one we all prefer. There is no doubt about it. Let us talk of only 3 commonest practical tablets which we are using. Which is your favorite and why out of the 3?
So I use levocetirizine. just once at night. And it is good because the patient gets good sleep also. The same patient who complains, I cannot sleep well and all. And no, so many patients come back saying that second day I can't wake up on time. So I then tell them, don't take it very late in the night, take it in the evening. So then next day the patient is alert in the morning, but he has had a good sleep.
All right.
My choice of antihistaminic purely depends on whether the patient has other atopic manifestations or not. If my patient has urticaria, histories of skin atopic dermatitis or urticaria, my choice of antihistaminic would always be the one which controls the itching part more. So I tend to prefer levocetirizine, or at times I do add Atrex to hydroxyzine salt. But if my patient is a pure case of allergic rhinitis with no chest involvement, I tend to prefer the non-sedating ones.
Okay. So what about fexofenadine and bilastine?
Even what she said to add, ma'am said levocetirizine. She said to add Atrex, that molecule. What I do increase the dose of fexofenadine, because nowadays in day-to-day life, day-to-day practice, nobody wants a sleepy day. They want to be awake. So why not to increase the dose of fexofenadine? Because even that is the clear-cut indication about from the derma people also, that in cases of allergic dermatitis, urticaria, you can have up to 4 times dose of antihistaminic.
So my opinion is that if it's a pure ENT case, any of the thieving suffice. As madam said, if it is night, prefer Levocet. If it is the daytime, last 2 are very good. But I have seen people sleeping with fexofenadine and bilastine also. Yesterday I have seen a young girl, she says, I feel so groggy after taking bilastine. So these are the patients, and she is okay with fexofenadine. So these are the very unusual, exceptional cases, but always talk to your patient, understand what is happening and then prescribe. But if it is a multiple allergic syndrome where the skin and other parts of the body is involved, levocetirizine takes up precedence because it is quite strong action and sustained action and within few hours only. Coming to the second most important pharmacotherapy is intranasal steroids. I think we all have been using intranasal steroids. There is no doubt about it. We have heard this across all the panels for so many years. Anything you want to add for INCS with azalastin, which is the flavor of the year?
You mean to, or rather you want to ask about the test of azalastin?
No, I want to ask what we could do, change in our practice so that we benefit other patient. I want to ask, do you think this is practical? The whole panel is about practicality and treating your patient so that you get the best result. Do you feel this is sustainable or practical? Your practical experience, please.
Yeah, my practical experience. Azalastin is absolutely bitter. In 2008, when I went to Singapore for Asia Pacific Congress, there, before that, I introduced azalastin of a company and the market. I was not aware about the test. That was the lesson in my life. Before prescribing drugs, better to test it by yourself. And it is so bitter. So many of my patients, they just disagree to use even steroid nasal spray because they are not aware whether this spray contains azalastin or not. So the test is the main problem.
So you like the combo or not?
Even the combo has got a bitter test. They tried a lot. I gave the feedback to the companies and they improved the test, but not to 100%.
Any other opinion?
Yes. So I always use the combo, and a lot of patients do complain the taste is very bad. In fact, initially I had told a few patients when I started using it, it was new in the market, the results are very good. And I had told them you use it after food, to which 2 or 3 patients came and told me we vomited after this. It is horrible. So now I tell the patients that you use the spray early in the morning and before dinner if required, yeah, but you gargle after that. Also, I explained to them that if it comes into your mouth, it is good. It indicates it has covered your nose from the front to the back, which is what we want. Yeah. So you use that and the results are much better than fluticasone alone. That's what I feel from my practice.
From practical point of view, I think not only me, all the people here are using everything. They are, each and everybody are using levocetirizine, fexofenadine, bilastine, intranasal corticosteroid combo, everything. But the thing is that all the patients are different.
Yes,
So
absolutely.
if we want to prescribe intranasal corticosteroids and agilastine, somebody he will accept it and somebody may not accept. So according to the patient, we can actually customize our prescription, because sometimes I may get a patient after taking fexofenadine for 1 month. Then if I am writing same thing, fexofenadine, then there will not be any value to that prescription. So obviously I will change to the bilastine. The only thing is bilastine that it must be taken in empty stomach.
Yeah.
Otherwise,
Yes.
the
The efficacy decreases.
almost
So it is
30% of the efficacy.
Absolutely.
And
1 hour
another
before
thing,
food.
that what is the character of the disease, that is most important than the drug. If we are facing blockers, then most likely intranasal corticosteroids will act sufficiently, but the only problem is that it can take at least 48 hours time for peak action. And most likely all the antihistamines are not that much of effect for the blockers, but it can control the sneezing and rhinorrhea part. So if we are only facing that sneezing, rhinorrhea, we can give the oral antihistamines in the milder cases, mild intermittent cases, but in all other cases, the first choice, at least for my side, is the intranasal corticosteroids.
So my take on this is, I'm talking about clinical practical things when we see in the patient. If you give INCS, whether it is propionate or furet, the results are very good and the compliance of the patient is very good. You give it to the patient for months, patient will take it. The time you shift to the combo where azolastine is involved, the compliance becomes so bad, because whether the taste is bad, the patient is vomiting, the patient will not use it and he will go back to the over-the-counter drugs like any antihistaminic. So what I feel the best thing is, you give INCS and you do a short course of antihistaminic, which will give good relief. You can use azolastine when you have people who say, I have a meeting and I want instant nose opening up, there is a blocked nose. That is the time where azolastine really helps. They accept the bitter taste because they have a presentation, it's a social meet or whatever, and they want an instant nose opening. You have to explain this to the patient, because maximum of the patient will go on oxymetazoline and land up with you with rhinitis medicamentosa. And it becomes, I have seen people taking it 20 times a day for 20 years. It was so difficult to break that habit. So please explain this part to your patient and their compliance will increase it. Coming to the another flavor of this year is Montelukast, because now the US FDA has said that it is a banned drug and it comes with a black box warning. As ENT people in this case, do you want to give LTRA or Montelukast?
Definitely
prefer
in aged patients, when the patient has got a hypertension, narrow angle glaucoma, prostate problem, cardiac problem, in those cases, yes, definitely antihistaminic with Montelukast.
So I feel that eventually this thing will change in 1 or 2 years, the use of LTRA in allergy, nasal allergy. Why it will change, we are coming to the few more slides, and please use it with caution. All our patients have Googled the drugs, they come to you. You can give it, but you should have a clear indication of giving it, and that is usually the lower airway involvement or some other skin diseases like urticaria. But the most important thing here you will see is the immunotherapy, which gives you relief from all the symptoms of allergic rhinitis. This is the recent ARIA guidelines. What I showed last was the old one. This is the recent update. And here they say that this is based on the real world evidence. Initially it was evidence-based medicine, now it is real world evidence. So this says that if you get a patient of allergy, send to an allergy specialist, and always the VAS which we are talking, the visual analog score. If you see, the whole thing is about the visual analog score. You have to see your patient, understand what the patient is going through, start treating, whether it is a steroid spray, oral antihistaminic, step up, step down, and if required, please refer to an allergy specialist. I think this is the step up, step down we all are following. INCS are the main stay of treatment. But here if you see, after giving immunotherapy, there is a way upward. That's the only reverse cycle, otherwise all the arrows are going down towards immunotherapy. This is just a slide because our patient had allergic asthma. GINA guidelines also talks about immunotherapy in asthma. I am not going into the detail. But important thing is the technique. Now allergy is not a local disease, allergy is a systemic disease. That's why steroids work so wonderful, whether it is an oral steroid or topical steroid. For nose, we are using nasal inhaler. For lungs, we are using the pumps and the other inhalers. But what we have to understand is the technique. Many times a patient says that I am using it, but I am not getting result. Please check the technique of the patient. If the technique is wrong, the patient will not feel better. Anyone on the technique about the nasal spray?
First and the foremost thing, I would like to emphasize that there are two most common molecules, fluticasone furet, fluticasone propionate. Fluticasone furet is the latest molecule at this point of time with best efficacy, longest duration of action. So if you want to prescribe, it should be fluticasone furet because that has got all the qualities, number one. Number two, fluticasone furet, what happens? We tell to the patient, this is the spray, just use it. This. No. First and the foremost thing, patient has to clean the nose properly, number one. Number two, in few of the preparations, priming is required. 1, 2, 3, 4, then the spray starts coming out. Another very, very important point, every time patient must shake bottle well. Otherwise, what happens? The drug deposits low down and only that solvent is get sprayed. So it is of no use practically. So patient has to clean the nose, shake the bottle well, tilt the nose like a head like this, put it inside, direct it towards the lateral canthus of the eye so that it is sprayed towards the turbinates, pump it and inhale inside, hold the breath for a while and gently exhale. 2 spray each nostril once a day, fluticasone furet, fluticasone propionate and memetazone twice a day dosing. Please be careful, be particular about prescribing like this. Thank you.
Yeah, thank you for that detailed explanation.
Just one thing I need to add to this. In all the recent guidelines, the EPOS 2020 and the ARIA recent modification with the care pathway, they have all emphasized on using saline nasal sprays. So you use saline sprays, clean your cavity first, and that actually adds on to your treatment that facilitates the activity of the INS, and that also improves the ciliary function. So using saline sprays, just washing the nasal cavity with saline definitely improves the AR symptoms. And it has shown in there are a lot of literature published now these days which supports this, and it has been added to the guidelines also now.
I just want to add another thing, though this is a silly point, but I used to tell each and every patient after prescribing this nasal steroid spray, don't pierce it. Because one of the most common habits of patients to just pierce the bottle because they used to think that.
So I think the best way to prevent, I have seen patient using sprays in all the forms, especially the inhalers. They will take inhalers, the rota caps, they will break it, they will swallow it and whatnot. They will put it in water and to take it. So the best thing to avoid all this thing is please show once to your patient the technique. If you are busy, you can't do it, keep an assistant, a nurse who can show it, and please check the technique. One patient came to me saying, I'm allergic to the nasal spray. The time I spray, I'm sneezing. I said, okay, show me. She was putting it right inside, touching the septum. Obviously, you're irritating the septum. The patient has to sneeze. But she was labeled as someone who is allergic to the nasal spray. So that was just an experience. Now, these are the latest euphoria guidelines, which says that if there is a severe allergic rhinitis, failure of the treatment, the important things which we have to do, apart from pharmacotherapy, is allergen immunotherapy, steroid surgery, and add-on therapies. But it says that if you want a long-term relief or cure, they are using the word cure here, the only answer is allergen immunotherapy to dust mite and pollens. Again, a recent update, these all things, you can please take a photo. These all are available. I can share it with you. This is a one slide which talks about euphoria, ARIA, EPOS, airway ICP, all the guidelines put together in one slide. And they also at every step say that please consider immunotherapy when you want the best results. So about immunotherapy, what is your opinion and how it is? Whosoever is practicing it.
So actually, allergen immunotherapy is the only disease modulating treatment available. It will modulate the disease. The patient will be desensitized, and it will actually balance the imbalance of Th2, Th1 cells which we have in our body. So once you give the patient AIT, it will actually balance out the imbalance of these cells, and this is the only way you modify except what you are doing medications, you are just giving symptomatic relief to the patient. This is the only thing which will modulate the disease.
I totally agree. Now, because of shortage of time, we'll just quickly go through the advantages of AIT. This will only decrease the symptoms, decrease your medication, will prevent present allergy, will prevent new allergies coming up, and the quality of life of the patient will increase. And as Nitika rightly said, this is the only disease modulating treatment. We'll go a bit quickly. We all know for CRS with nasal polyp, we give lots of steroids. We know the side effects. But now the recent guidelines say you should talk about biologics. We have this minority of the patients, like this was where there was the patient declined the surgery. This you have to talk to the patient. Patient has a right to refuse surgery, and in such cases we talk about biologics. Now these biologics are the game changer now in nasal allergies, and many things are approved. Briefly, what is available in India, and do you do this? Anyone?
Currently, we have we have anti-IgE, which is omalizumab, and we have biosimilars to omalizumab, which will reduce the cost. We are in the process of getting dupilumab, but the cost would be an issue in the Indian population. Definitely, if a patient is there with multiple episodes of surgery undergone and they decline surgery, or you have a patient who is not very well responding to the AIT and has asthma, these are the patients who would be, and there will be an indication to start biologicals to these patients.
Okay, so as she rightly said, how do you decide? There are three criteria which I want to point clinically what you can do. One is that evidence of type 2 inflammation that you get to know by the tissue eosinophilia, which we talked in nasal polyp biopsy, or a blood test where you see eosinophilia or a total Ig level increased. Patient is regularly using corticosteroid. The quality of life is hampered, which you know by your snot or VAS, and the smell is lost, or the patient has asthma. So because my patient was fitting here, we did this for the patient. And this is the latest precision medicine where we are talking about patient preference, whether the patient wants surgery or biological. My patient chose biological, and this is how treated the patient. We give oral corticosteroid to begin with so that we decrease the size of the polyp, because there are local, lot of inflammatory markers there. We want to reduce that. We gave INCS. We treated the asthma. We started on immunotherapy to dust mite pollens, and I gave her injection omalizumab for 4 months. And within 4 months, this one was the result. Patient stopped taking omalizumab after that, but she's still on immunotherapy, doing very good. Now she's going for a physiotherapy at Pune, staying at hostel, and we all know hostel is a place for dust mite. So with this is the last slide, and one thing I want to say is that whenever we see such patients, this is anaphylaxis, and this is a nightmare for any doctor. And whenever any patient goes to the casualty like this, everyone gives Avil and Hydrocol. I'm not saying it is wrong, but the treatment for anaphylaxis is adrenaline, adrenaline, and adrenaline. Please take this message from here. Tell this to your colleagues and give adrenaline to the patient who is in anaphylaxis. So with this, the learning points are: take a detailed history, take quality of life, other comorbidities into consideration. For Th2 inflammation, any ENT surgeon can do a CBC for eosinophil, Ig level, and a polyp histopathology. And AIT is the only disease which modifies treatment in the allergies, and it changes Th2 to Th1. So allergies can be diagnosed, allergy is treatable, biologicals are a game changer, and the treatment for anaphylaxis is adrenaline.
Dr. Sunita, this is what you talked about anaphylaxis. At this point of time, as all leading ENT surgeons are here and across India, what is in my hand is EpiPen. Very sorry to say, not available in India. This is pre-filled epinephrine. If a patient suffers from anaphylactic attacks in the past, he should keep this kind of EpiPen with him. And what he has to do, just even with the clothes there, put it here in the enterolateral aspect of the thigh. And that's the remedy at this point of time, but very sorry to say, not available in India. I have brought it from Helsinki. But we all should try and we should make this available. It should be our joint effort.
So though it is sad we don't have it, but I am very proud to say we Indians are jugadu and we have a solution for that also. Nikita, in one sentence, please.
So you can actually use an insulin syringe, which we have in routinely use in for other things. The insulin which people use to inject in. You just fill up 0.3 ml or 0.5 ml depending on the patient's age. Fill up that insulin syringe with ADR. Pack it in a spectacle case. Hand it to your patient. Replace it every 1.5 months. That is a simple, easy, and cheap way to sustain an EpiPen, because EpiPen is not just available and it's very costly also. So
And
that
this thing what Nikita is saying will hardly cost you only 50 rupees.
yeah,
not
it's
more
very
than
very
that.
cheap.
We
An
make this
insulin
kit-
syringe and an ADR vial. That's it.
We make this kit and give it to our allergy patient. We teach them how to do it and it is a life-saving thing. So with this we end, and I hope we have given you a lot of tips which will convert this theory into practice and how it will bridge your gap in helping your patient live better quality of life. Thank you once again, sir.
Thank you, Sunita, and all the panelists. I think there are some questions coming in. Guwahati, you have a question, please go ahead.
Yeah, hello.
Yes, you're audible, go ahead, please. We can hear you.
I want to ask, as Sunita mentioned that your biologics is the game changer. With the dupilumab, the IL-4 and IL-13 blocker will be a change of the nasal polyposis.
Yes, sir. So, Nikita, you want to answer or I can? So, dupilumab is actually the drug of choice for nasal polyps because it is a IL-4, IL-5 and 13 cascade which is at fault in nasal polyp. But in India, it is still not available and we are still in the process of getting it. So, the second best option which is available is a omalizumab. Omalizumab is an anti-IG and it was first of its kind. And the case which I showed you, I have given her omalizumab because we don't have dupilumab. Otherwise, that would have been my drug of choice.
I want to help. Now, cloth is available, a 0.6 micron that for your house dust mite for the pillow and the mattresses covering.
So the covering was initially available by the name of Allergo cover, but post-COVID they have stopped it. We have lot of things available online, but I still am not sure about the quality of such covering. So I have not seen it to be of any use for my patients.
Okay, thank you.
Right, so if there are no more questions, we would like to
Yeah,
thank
there's,
Sunita.
excuse me, sir.
Yeah.
There's a question from Indore.
From Indore, okay, go ahead.
Yeah. Good afternoon, sir. I'm Sanjay Gupta. How long the intranasal corticosteroid we continued after starting the immunotherapy?
Anyone wants to answer or I answer? So in my experience, once I start the patient of immunotherapy, within 1 to 2 months, the corticosteroids are stopped. You just have to explain the patient about the triggers that immunotherapy, whatever we are giving it to you, whether it is dust mite, pollens, it will act for that only, not for other allergens which you have to avoid like cockroach, fungus and all those things. But once in a while there will be a trigger, explain them what are the triggers. Like for in Mumbai now the trigger is season, we have a viral infection going on. This all will aggravate. So once in a while they will have to use oral antihistaminic and the spray. Be realistic, explain it to them. They understand very well and it makes everyone's life easy.
Okay, thank you.
Recently, I have read an article regarding probiotics being used. So is it really, I mean, effective and...
So whether it is probiotics, Chinese herbal
Sir,
medicine,
एक question.
and acupressure, all these things are in the latest EPOS guideline where they have not found any evidence-based medicine to prove that they help. They help in few cases of epigenetics where if the mother is given probiotic and allergen immunotherapy, chances of the baby getting allergies decreases. But still they have not come up with a 100% answer.
There's actually Lactobacillus paracasei and Lactobacillus fermentum, which is a combination of a probiotic. This actually facilitates the imbalance, the balancing out the imbalance of TH2, TH1, ma'am. So it is definitely, it plays a role. There are some literature supporting it, but yes, definitely we need to see that what is the response in the Indian population.
Yeah.
There is no
So having
particular
said
study
that,
for that.
I totally believe in evidence-based medicine. 2-3 decades back, it was expert opinion on a subject. Then came evidence-based medicine where things were proven. And we have this evidence-based pyramid. So we have to go for the meta-analysis, randomized control trial, and whatever is on the top of the pyramid, whether it is an international guidelines and all, accept it, start doing it. But as Indians, we should come up with our own guidelines, which AOI has done so well last year, and we should stick to it because I can see we have such good clinical data which the world doesn't have. I have gone to so many allergy centers in the world, and we can itself make our own, guidelines, and which I think we should easternize the Western world more now. Having said, I thank you once again to the whole.
Any other questions? Anybody else with a question?
Sir, one question from Indore.
Yeah, go ahead.
Sir, whenever we are starting like sublingual immunotherapy, first we start on primary dose, then we give a booster dose. On starting of the booster dose, should we again start with the intranasal corticosteroids and montelukast or fexofenadine or levocetirizine? If patient presents with allergic symptoms.
You have there are two phases in sublingual immunotherapy. One is the escalation phase and other is the maintenance phase.
Okay.
Once the patient has crossed escalation and on the maintenance, he will hardly use INCS, only in exceptional trigger cases, which I said. But if it is a once in a while, you have to understand every sneeze is not allergy also. It can be irritant, like if it is a perfume or someone is cleaning the house and so many other things. That time a simple oral antihistaminic can also work. We still use oral antihistaminic for the mild intermittent cases. So in that case, you can do it.
Okay.
But
Thank you, ma'am.
the success of immunotherapy depends on how you're doing the test, how you're selecting the allergen, whether you have gone back to the second history of the patient, correlated your finding, and then the quality of your allergens. If all these things are set, the success rate of immunotherapy is very high.
Right.
Thank you, ma'am.
People are, I think, little bit confused about once a patient is on immunotherapy, whether he or she should use intranasal corticosteroid, antihistaminic, montelukast or not. With immunotherapy, each and every drug is permissible. Absolutely, there is no strict guideline or nothing of that sort that if a patient is on immunotherapy, he or she should not use intranasal steroid or inhaler or antihistaminic. Absolutely no problem at all.
Thank you. Thank you very much. I think we'll have to wind up here and would like all of you to join for a photograph. And also, can I have the mementos for these?
Thank you, panelists, to make this discussion so fruitful for our audience. I request Kirtane sir to please come and felicitate the respected panelists.
And from Indore, respected Professor Kirtane sir, we thank you for your brilliant conduction of the program and thanks ALKEM.
Thank you, Sanjay.
Dr. Kirtane, it's a really pleasure to see and listen to all these deliberation under your...
I didn't know the big boss was in there listening.
Sir. I am here all the way from Bhopal because I know that it's a...
Achha, you came to Indore, okay.
Yes, sir. It's a pleasure to always see you and every word from your mouth and every program which you organize. It's really a treat because you always insist upon the quality and the best thing deliver. Sir, all the academics which we have, it's all because of you. And we are really indebted to you for whatever we are doing in our clinical practice. It all because of you. Thank you very much, sir, from the bottom of my heart.
God bless you. Thank you.
Dr. Sunita Shukla. Dr. Subir Jain.
Now for this session, I would request
Dr. Dr. Nitika. I request Associate Vice President of ALKEM Magna, Mr. Prince Uppal, and AGM, Mr. Yeah, to also please come on the stage. I also request Dr. Kaushal Seth to please come on the dais. Requesting Mr. Prince to please come on dais and consider our mentor, our guide, a brainchild of this program, Kirtanesh. So with your permission, can we go out for the meeting?
No, you want to continue? I don't mind.
We wanted to start the lunch.
This should be soon dinner otherwise. So, thank you very much. And as I said, if you have your suggestions for the next time, the pattern, videos, live surgery, cadaver, whatever, topics, and some speakers or people who you know are doing good work, who you feel can contribute significantly. Every table has a pad. Just put your name there, your contact number, and your recommendation. Continue in the same video question answer session, live surgery, recorded videos, lectures, whatever you want. It will help us give you a better program every year on end. Try to improve on what quality of information that you take home from here. So please just scribble on a pad, leave it with the people from ALKEM, and we'll take care of it. Thank you. Thank you very much. The laptop is
So thank you delegates for your active participation. Please enjoy your food.